Good morning, and I would like to welcome everyone who is present in the Chamber and those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would also add that for those of us in the Council Chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council Chamber through the rear doors, free reception, and assemble in the car park at the front of the building and await further instruction. I would also request all members to place their phones on silent and to ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep these succinct and concise. As the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies from Councillors Katie Chalmers, Sandra Harrison and Jane Lofhanger. We have Stephen Woodliff as replacement member for Katie Chalmers, but he's got to arrive yet, Chairman. Councillor Parkin is going to be late, and we've also received apologies from Councillor Woolley. Thank you, Chairman.
Thank you, Trina. We'll move into agenda item 2, in which case, declarations of members' interest. Do members have any interest to declare at this point? Councillor Thompson.
Thank you, Chairman. Just to inform you that both my wife and myself are currently patients of ULHD. Thank you.
Thank you, Councillor Thompson. That's noted. In which case, we'll move on to agenda item 3, the minutes from the 14th of December 2022. You'll find these on pages 3 to 13 of the agenda pack. And as I believe these will have been read, I'd like to take these on bulk. So do I have a proposer for these, please? Thank you, Councillor White. Seconded, Councillor Smith. All those in favour, please show. Thank you. That's carried. In which case, we'll move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and supplementary announcements were circulated on the 17th of January. Are there any questions on these? Councillor Smith.
Thank you, Chairman. With respect to the critical instance declared at Lincoln County, do we know what work's been done to prevent future critical incidents needing to be declared? Thank you.
Simon, would you like to come in?
Thank you, Chairman. I suppose the short answer is we don't know. It is something that perhaps could be raised when representatives from United Lincolnshire Hospitals are attending the committee meeting on the 15th of February, the committee's next meeting. Thank you, Chairman.
Thank you, Simon, and thank you, Councillor Smith. They were meant to be with us today, but because of the pressure they're under, obviously, it's been a difficult one. Councillor Allen.
Thank you, Chairman. I've got one question on item 3, your item 3, and one on item 4. The item 3 one is to do with the bullet points, and it's to do with what comes out frequently in various comments made by various parts of the NHS in terms of exceptional demand, because it does seem to me that that needs defining in some sort of way if at all possible, because it seems to me that the NHS operates critically, and 2 extra patients then tip it over the edge, and whether 2 extra patients is an exceptional demand that's being placed on the NHS, I think needs defining. So that's what I would like to see, if at all possible, some information that goes with that to justify these sorts of comments. If there's a degree of criticality permanently within the national health and it just tips over with an exceptional additional demand rather than exceptional additional demand, I think we need to know. And the second item is to do with the Humber Acute Services Programme. I did read the report with interest, and it did seem to me that the Senate, I think, had made some reasonable comments in relation to the report that had been put to them, one of which was putting 6 options for consideration is unreasonable. And the second one was it's pointless putting forward options when we know we can't deliver whatever the options are because we haven't got the workforce to do so. So it was comforting, I suppose, in a way, to see some element of realism within the report, which doesn't frequently appear elsewhere within the NHS reporting systems.
Thank you, Councillor Allen. Yes, I would totally agree with you on the comments on the Humber Acute Services Programme. Clearly, there's 3 members, I think, that are from this council that will sit on that board when it moves forward anyway. But yeah, I think you're absolutely right in what you're saying there. In regards to the critical incidents, we can make sure that we have a clearer definition of what exactly is, causing that, and what the difference is between, not being critical and so on. But I mean, it is a regular occurrence at this time of year, to be fair, with the pressures due to winter, really. But we will make sure that that is clearer, certainly. Any other questions, please? No, in which case, do I have a proposer that we note? Thank you, Councillor Higgs. A seconder? Thank you, Councillor Allen. All those in favour that we note my announcements? Thank you, that's supported. In which case, we'll now move on to agenda item 5, the Ashley House consultation. This item was circulated as part of the agenda pack on pages 25 to 41. The consultation document was also circulated to the committee on the 13th of January 2023. I'd like to welcome our presenters via Teams, Sarah Connery, Chief Executive for the Lincolnshire Partnership NHS Foundation Trust, Chris Higgins, Chief Operating Officer, and Andy Ricks, Chief Operating Officer for the NHS Lincolnshire Integrated Care Board. And I'll hand over to you for about 10 to 15 minutes if you can, and we'll take questions at the end.
Thank you very much, Chair. Hopefully you can hear me okay. My name is Sarah Connery. I'm the Chief Executive at Lincolnshire Partnership NHS Foundation Trust, and I want to thank the committee for inviting us here today to talk about the future of Ashley House in Grantham. We have been to the committee before. I suppose it goes without saying to talk about the temporary closure of Ashley House, which was deemed the clinical right response to do while we shored up our staffing during COVID, which actually allowed us the opportunity to pilot the expansion of our community transformation programme going forward. The Trust and the Integrated Care Board believe we've got two options now in terms of what's the permanent solution for the Ashley House service going forward, and these are presented today in the paper. We will assume that the papers are read in the interest of time and to allow to maximise the time for comments and questions. As you said, we've got the consultation document included within the papers, as well as a pathway document that talks about our services and our acute pathway and how rehabilitation services fit into that pathway. In terms of those two options going forward, I will hand over to my colleague Chris Higgins, our Director of Ops, to go through those. But I just want to draw the committee's attention to the actions requested here today, which is to consider and comment on the consultation document on the proposed service change at Ashley House in Grantham, and also to agree that a draft response is prepared for the committee to approve at its next meeting on 15th of February, based on the committee's comments at this meeting, which we absolutely welcome. So I won't take up any more time. I'll hand over to Chris to talk about those two options, and I'm delighted as well to be joined by Andy Ricks from the Integrated Care Board, who is in support of those two options going out forward for consultation. So over to you, Chris. Thank you.
Thank you, Sarah. Hopefully everybody can hear me. Just as a bit of a starter, just to give a bit of an overview of the services we're talking about, just so everybody's clear. I know people have had a chance to read the document, and we have spoke about this previously, but I thought it just helpful just to run through just as a headline around the service we're talking about in particular here. So Ashley House is what we call a low dependency rehab unit. It's what we call at the end of the pathway. It's the stage before community. So it's a service that's not supporting people in crisis that often we hear about. It's about people who've got a long and severe and enduring mental illness that's often lifelong. And so the people who would come into Ashley House are those that have either had repeated admissions, or quite often people have had long stays in hospital, sometimes years in hospital through different needs. And this is the end of that pathway where we're transitioning people back into the community. So it's about enabling people to live with a mental health condition and often developing the skills that's needed to live an independent life, whether that's budgeting or access to education and employment. And that's a role and function that's been provided by both Maple Lodge in Boston and by Ashley House in the past. And what we've known for some time is that there's a bit of a gap at the end of that people will be in an inpatient unit that's providing 24-hour care with doctors and nurses and other professionals supporting them. And then the next step is into the community, where often living independently, reliant upon other services that are not as intensive and can't provide that level of support. And so it's something we wanted for a while. It's now part of the national agenda through the long-term plan for the NHS, is to introduce community rehab services across the country. So at an early stage, we set up a community rehab service. We got some funding to cover part of the county. It was how the funding was rolled out. So we set up a service in Lincoln and Gainsborough, and that proved really successful for the people that used it. And what we heard from people at the time is that that enabled to have that ongoing care and support in the place where they live, where they can get that extra support, to that helping hand to access education and housing and other things that are really important to them, and also to develop that care network. And the community rehab service has been really effective in that way. Now, since the unit was temporarily closed in back in 2021, we took the opportunity then to use some of the resource that's aligned to Ashley House to both prop up some and support some of our gaps in our other inpatient areas at the time, but also to take some of that resource and to strengthen and expand the community rehab team so that it could cover Grantham. And in doing so, we were able to support 15 patients that were otherwise either in Maple Lodge and Grantham in the community in a much more independent way. And that certainly seemed to be successful, and I'll go through why that we think that's the case. What it does mean is that those, now the offer for people at that end of the pathway is there's a couple of options. Those that need that level of inpatient care, that 24-hour care to provide that structured support back into the community, can have that at Maple Lodge, which is a county-wide service, or they can have it in the community rehab team, depending on their needs. And so what we're able to do through that process is match the service to people's needs in a much better way than we did before. What I would say is just worth again pointing out that which does impact obviously on people and how they access services, is that both units have always operated on a county-wide basis. So it didn't automatically mean that if you lived closer to Grantham, you went to Ashley House, or you lived closer to Boston, you went to Maple Lodge. Now, we always tried to place people as close to home as possible, but that wasn't always possible because of bed availability. So people went to the next available bed. And we see that when we look at the spread of admissions where people have travelled from to access those units across Lincolnshire. It is a widespread across the whole of the county for both of those units. What we've found is, since we've been trialling this new model, is that it's been successful on a number of fronts, which has led us to believe and propose that it's the right way forward and propose the changes that we have. And the way we've measured that is twofold. One is about timely access to appropriate care and treatment when it's needed. And on that particular note, we've seen that when patients need to access appropriate rehab care, they can either access the community rehab team or access Maple Lodge, and there's been no delays in people doing that. The beds are available when people need it. We've got sufficient beds, and the expansion of the community rehab team has been available for the people to access it in a timely way. So the timing of access has been appropriate. We've also seen that with that new model, more people have been supporting the community. Less people need to be supported in an inpatient environment. And so what that means is the demand for that low level rehab placements is less. And we've been managing all the demand, all the need for inpatient care at Maple Lodge. And we've always been able to admit patients to that unit, rarely getting up to 100% occupancy. And that remains the case today. So anybody needing that level of care, there is a bed available for them so they can get the appropriate access. And the third piece is around patient experience, and care experience indeed. We've been talking to patients' carers throughout this period to get their views about what that feels like, what's important to them, does this work for them? And overwhelmingly, the feedback has been positive. People generally want to be at home with their families and their care support networks. They don't want to be uprooted and moved into an inpatient setting. We would, however, acknowledge that for some people that's necessary and it's the right thing, and it is what some people want. But as I say, there has been and continues to be beds available for those people that need it when they need it. That's led us to options and that are the feature of the consultation. And really where we are now is at a crossroads of where we go next. So we've got two options available. One is that we continue the current model. We accept that this is a better way of working and it meets the needs appropriately. Alternatively, we could step down the community rehab team back to Grantham, so to Lincoln and Gainsborough, and reopen Ashley House. And it's always been the ambition and always will be to have a county-wide rehab service. But at the moment, as you know, money is tight. There are multiple priorities to draw on, and there isn't a funding source identified to be able to expand community rehab, as well as having Ashley House open at the same time. So it's a bit of a choice at the moment between one or the other. The alternative is we do scale back the rehab team and open Ashley House. What I would say on that is, and what's led us to put this proposal forward, is that we're successfully managing people in the community, and people are saying to us this is a better way of receiving care. And it seems, when you think about what people are saying, what we know as a health and care system about trying to promote independent living, what the national strategy is saying to us, it seems counterintuitive to open a unit and admit people back into hospital who don't actually need to be there. And so we're saying, actually, is that the right thing to do? However, what we do know is we need to do some more work through the engagement process, with the consultation process now, to really understand the impact of that potential change for good and for bad, and what that would mean, and what we might do to mitigate those issues and concerns that arise. So I think the main areas of concern that we need to be focused on, or the consultation currently is focused on, and we welcome your views on this, is about access. Can people get the right access to the right sort of care and treatment facility to meet their needs in the right place at the right time? And what does that mean? And I think that's really what we're trying to tease out here is we know that some patients will have to travel a little bit further, and you'll see from the pack that we provided that when we've done the analysis of those people that were admitted to both Ashley House and Maple Lodge in the 3 years prior to the temporary closure, we can see that people have travelled from all over the county to access that support. However, there are some people that have had to travel less than others. And if you look at Ashley House specifically, when you map the distances travelled from home address to Ashley House, and then where they can be supported now, about 12 people a year will travel less to access care. And I think that's really important to note, is that because people have travelled all over, because there's a community rehab service available in people's own communities, 12 people a year will travel less. Conversely, about 5 people a year will have to travel further, and that's those people that were living in Grantham and the surrounding areas. And if they do need an inpatient admission, then they'll have to travel to Boston. So we've got to acknowledge that, and that's something we want to understand more thoroughly through the consultation process. And indeed, there are other things that we can do to help support that if we do proceed with that as the preferred option. How can we help people to access care, not the patients travelling, but also their friends and family, and making sure those care networks are supported to be continued? And I think that, again, it's about understanding what that looks and feels like for people who might be using the service in that way, and indeed are currently using that. Another important point just to draw out is that with the new service model, as we've got it running today, is the capacity is greater. So Maple Lodge can support 15 patients, Ashley House could support 15 patients, so a total of 30 patients being supported at any one time. In the new model, there's 15 patients being supported at Maple Lodge, and the community rehab team has a capacity to support 40 people in the community, plus an extra 20 that are transitioning out of inpatient services. So you can see the actual capacity of the service has grown considerably to support more people. And again, that we think that's a really valuable contribution to the offer in the Lincolnshire system. So where we are now is that we're saying, from the feedback we've received, from the experience we've had as a service provider, we can see the benefits here of continuing the model. We feel that to put people back into hospital when it's not necessary is probably a retrograde step and goes against what we feel is the right direction of travel, both in terms of national policy and what we're doing locally. And we want to consult with people about what that actually might mean and really understand the full implications of that in a more formal way. So I'm going to pass back over to Sarah now, who can talk through a bit about the next steps and really the contribution we'd like from you today.
Thank you very much, Chris. So In terms of next steps, the consultation is now live. So you'll see from the consultation pack the list of events that we've got all the way up to the end of March, including the public events as well as the survey. I do just want to highlight on the website link that there is a service user audio there of someone who've actually used the community rehabilitation service and inpatient services, and how the community rehabilitation services has helped that lady to have a much better quality of life, and how it's helped on her recovery journey. So I would urge you to have a listen to that audio. So just refer back to the ask of the committee today in terms of considering and commenting on the consultation on the back of everything that we've talked about so far, and to agree that draft response to the consultation. So thank you very much, Chair, and we're really happy to take comments and questions. Thank you.
Thank you for the presentation. Our first question comes from Councillor Allen, please.
Thank you, Chairman. It's an interesting issue, and it's an interesting proposal that's been put forward. I don't have any difficulties in looking at different ways of treating mental health, and that's something that's been ongoing for some considerable period of time. There's a number of clarifications I think I'm seeking from the presenters today, or during the course of consultation, in terms of these things being raised by others. I'm sure that there are lots of people who have the support from their families and friends, and probably treatment in the community is more appropriate, and indeed probably preferable even now than long-term stay in a home. But equally, I think there are quite a number of people who probably don't have that support, and that is probably the best way of actually providing that support. So the issue then becomes how best to actually provide the service overall to cover both those different types of patient. And it was mentioned that the current change that has been operating in the south and west of the county has achieved a lot of success, and indeed for people who have used it, as we just mentioned, have found it a better way of dealing with things. I do wonder though whether there are equally people who said, you know, that I prefer, because I don't get the support in the community, the home environment, as it's possibly better for me. So the difficulty then becomes, and it was mentioned that there has been success in terms of the new model that's being used in the south and west, although I'm not totally sure how that success has been defined. Is that success in terms of staff being able to do the job as they see it easier, or is that success in terms of patient outcomes and community outcomes as well? Because it's not just patient outcomes. I mean, we know from experience and from what's reported that sometimes things do go wrong, and there are consequences within the community for operating this particular sort of model. So I would like to have some sort of comment in terms of what it is that determines that this success. Is it just the resources and the use of the resources, or is it genuine outcomes, both for the patient and for the community as a whole? The second thing is, it does seem as though rolling out the model, closing Ashley House and reallocating the resources, and rolling out the community model across the county as a whole, does depend on reallocating the resources into additional workforce. And it says it could go up from 14.8 to 32.5, and it may well need to go up from 14.8 to 32.5 to provide the level of support that's required, because it must be more time consuming actually dealing with patients in the community than patients at one location. But it then goes on to say, although we're not totally sure we can recruit all those resources, so it strikes me that there is something that needs to be said in terms of guaranteeing that. Otherwise, I can't see how this new change in the model is going to succeed. Clarifications, I'm not fundamentally against it, but I think the report doesn't necessarily show how success is going to be defined, and that it is possible to operate in this model. We've seen other reports already today, and no doubt we'll see reports in due course that say we can do all sorts of things if we've got the resources to do so, but we're not totally sure we can get the resources to do it.
Would you like me to start off on that?
Yeah, thank you, Andy.
Thanks very much. A very acute observation, and thank you for that. I mean, there's an old saying that goes that beauty is in the eye of the beholder, and by the same token, success is how an individual experiences it. So you can look at what determines success through lots of different lenses. Ultimately, the measure of success is that an individual who has been dealing with lifelong mental illness at a low level and may have required significant periods of time in hospital, reports that they are now able to function in their own home or in the community, and that their level of clinical support has diminished. And of course, the success of the patient recovery is the most important thing, and we do measure that and we do track that, and that is the goal for all patients who access any clinical service, whatever it might be. But equally, if you're a member of staff, you might measure the success of a service by your job satisfaction. From an organisational point of view, it might be that your recruitment and retention of staff and your ability to employ new staff who want to work in a service that is satisfying and meets their needs works really well. And you can look at success from a societal point of view, you know, empowering communities to support and care for people who, you know, find themselves in difficult positions. So there are lots of ways to measure it, but I think ultimately it is about patient experience, the experience of families, and particularly that they feel supported and they can see a change in the disposition and health of their loved one. In terms of the recruitment question, because obviously there are recruitment issues in the NHS, and LPFT are not alone in some of those challenges. I mean, I think Chris is better placed to comment on that, if that's okay. Thank you.
Thank you, Andy. And absolutely just reiterate what you said there, is that the goal of mental health services is predominantly to give people the skills and capability to just get on with their lives, contribute to society, and depending on the severity of people's mental illness, sometimes that takes them away from that. And if you're in hospital, it absolutely takes you away, and life tends to be on hold for a period of time. And what we're trying to do here is to give back that independence, to help people to not only feel able to live their lives, but also then be able to contribute back into society through, you know, work and education. So really, really important. And those are the measures of success, and that we'll be talking about. But absolutely, the satisfaction of people, staff and patients, is important within that. You also just mentioned about the support networks, and absolutely right is that not everybody has a support network, and that's again the role of community rehab services, is to be out in communities with people, to be able to be that holding hand, to be able to access community groups and other networks. Alongside this is we've got our community mental health transformation programme that's seen huge investment and continues to see further investment in community support groups. And so again, community rehab team would facilitate access to those groups so people can create their own support networks. But also for those that really need that more structured support in a residential setting, we're working with social care colleagues to be able to access appropriate supported living. So hospital is not a forever home. It's a hospital. It's a short, well, it's a period in somebody's life. We need to move on to people's forever homes, and whether that's and as independently as possible. For some people in their own flats, some people might be in residential support, but the rehab team can coordinate that and facilitate that access to maximise independence. And specifically about the piece about recruitment is that where community rehab differs from our other services, our traditional services in mental health, is if it's a ward or a hospital, that you need doctors and nurses, and they're the roles that we found it particularly difficult to recruit to. The community rehab team does need some of those in place, and we've got those in place, but the growth in roles will be around occupational therapy and community connectors and other people that can support people to access benefits support and other things, so that, and we're much more confident that we can recruit to those roles. So I don't envisage the recruitment to community rehab team being anywhere near the same challenge that we've got in other services, and indeed we've got people we know that are quite keen to come and work in the service now.
Councillor Allen, you'd like to come back?
I would do, Chairman. Well, I look forward to something that shows eventually how successful the change has been. And I'm comforted in terms of the comments that you, unlike other parts of the National Health Service, don't seem to have a recruitment problem, which is quite good. Just one final level of clarification, if that's all right. Presumably the people in the homes at the moment have a 24/7 support of some degree. Can you tell me what level of support the patients in the community will be getting? Is it going to be 9 to 5 or is it 24/7 in some way? Because I did read another report about adult mental health care, and it does seem to me that once you're outside the system or once you're in the community, you are almost limited to helplines and nighttime cafes as a way of actually getting the support that you need if you haven't got families and friends.
Yeah, I'm happy to come back on that. Just picking up on the point about recruitment. Certainly, mental health services are experience the same issues around recruitment challenges that other parts of the health system are, and indeed, I think we've spoken to committee about that in other services. This particular service, community rehab, lends itself to a range of alternative roles that we find much easier to recruit to. So, that's why we're so optimistic about that. In terms of hours of operation, the service is going to operate 8 till 8, 7 days a week. And because of the staff to patient ratios, we can offer really quite intensive support during those hours. And indeed, we can connect in with our own LPFT services and the wider community services, crisis cafes and others that are all part of the extended care network. That, I suppose the principle being is if somebody needs support needs support beyond that intensive 12 hours a day, 7 days a week, that probably would be the indication that they need to be in a more inpatient, an inpatient environment like Maple Lodge. And I think that's the kind of differential there, is that if we can support people in that, with those hours, with that level of support, then they're able to live independently. If they're not, then that's probably the tipping point at which we would recommend an inpatient admission.
Okay, thank you. I've got Councillor Smith next.
Thank you, Chairman. There are a number of concerns I have with the report. Firstly, it seems the need to travel or the distance thereof and the positive and negative of which can be interchanged when it suits. We've heard a number of reports at this committee where the need to travel is deemed to be acceptable for better quality of care, yet here the need to travel is being used to say that a current system that, in my opinion, works should be altered. Councillor Allen has already alluded to the issue around the hours of care, and in my opinion, in reading the report, it tries to state that the level of care and hours will be the same intensity of 24 hours as it currently is, which obviously, as has been alluded to, simply isn't the case. Thirdly, the report states, and fairly enough, that the 15 beds in the Boston facility, which is Maple Lodge, haven't been fully utilised. Which is true, but what it fails to highlight is obviously the expected level of growth Lincolnshire is required to take in terms of new dwellings and properties and etc. And a 30-bed provision for a population of nearly 1 million people is hardly excessive, and I believe the occupancy is at about 83% now. So it wouldn't take much for those 15 beds to be occupied and a need for those beds to be used at Ashley House. Additionally, we are yet to fully understand the mental health implications of COVID lockdowns and the inability to see clinicians. Finally, Chairman, and this is a purely professional and personal opinion, I have worked with numerous people of various different backgrounds who have needed support, and community mental health has totally failed those individuals, and they have been left to the organisation I used to be involved in, and we weren't mental health practitioners, we never claimed to be. We were joining up the dots and trying to get the support these individuals needed, and it was hard enough then. If you reduce the number of beds that such a facility like this, which is actually what most of those people may have needed, but trying to actually get into it was very, very difficult, and this will only exacerbate it. I also think the step from, as has been alluded to, a number of these patients come from secure wards originally to a step down at either Maple Lodge or Ashley House. If they are then put back in the community without that step down, certainly to my mind seems to be almost like a cliff edge. You go from a very intensive level of support to straight back into the community with networks, and that's if you have, as Councillor Ann said, if you have networks that you're fortunate enough to have. I firmly believe that Ashley House should remain open, Chairman, and if we lose such a service, we have form, not just in Lincolnshire but across the country, there's form for this. If you close something, you don't get it back. Let's be honest, if this closes, I cannot see in 5-6 years, however long, somebody coming to committee here and saying, oh, we have the resources now to find a new building, pay for the land, because the land will probably be sold and the building will probably be sold for something else. I doubt it'd be kept. You're not going to have it, because then everything gets more expensive. And lastly, Chairman, what I would say is the psychiatric intensive care unit was closed in Lincoln. Patients were housed here. So what would happen if this building wasn't here? Where would they have gone? They'd have gone out of county. So to me, that emphasises the importance of actually having this building and having this resource. And I really think it would be a retrograde step for mental health services if we lost it. Thank you, Chairman.
Do you want me to start? Because there's quite a lot in there, so colleagues will want to come in on some of the points. So thank you for the challenges and the questions. I think there is some points of clarity to be made there, that the patients from the psychiatric intensive care unit haven't been going to Ashley House. That Ashley House is currently temporarily closed, and as Chris mentioned earlier, has been since 2021. So our point is that the evidence would indicate that the current demand for services is being effectively met within Lincolnshire using the community rehabilitation model that we've talked about, as explained in the paper. So in terms of the psychiatric intensive care unit patients, they have gone to our acute wards, and again, we haven't seen an increase in our out of area patients. I don't know, Chris, whether you can talk about the current numbers, but they have been sort of around 0 or 2 to 3, despite the temporary closure of the psychiatric intensive care unit. So this is a different cohort of patients ultimately that we talk about. What we have done is facilitated, as part of system working, a care home to move into Ashley House to make sure, while some heating failed at another provider, to make sure those patients didn't have to go out of area. Again, that's temporary, just through winter, just to make sure that we're meeting the needs of our population within county as much as possible. So I hope that sort of clarifies that. We currently haven't got Ashley House providing rehabilitation care. That is being held, we would argue, in an effective way by the community rehabilitation team. It's a really valid point you make around the future, the impacts of COVID, and as part of our mental health alliance within the system, we are looking at our 10-year ambition and strategy in terms of what will be the needs of the population going forward, in terms of the demographics, our ageing population, and what services do we need in order to meet that potentially increasing demand going forward. And as a alliance, so that includes local authority colleagues, primary care, the voluntary sector. The ambition is to keep people well in their communities rather than rely on what you could argue is outdated hospital care. In terms of the intensiveness of the support, again, really great challenge, and tying into one of the earlier questions as well from Councillor Allen, we're really happy to come back to Health Scrutiny Committee to talk about some of those measures of success and really listen to the people using the services about what works well for them. And in terms of them having a happy and healthy and meaningful life, in the community, that is facilitated better by the community rehabilitation model rather than dependency on an inpatient model. So I hope that covers some of the points, but I'll stop there and invite perhaps Andy and Chris to come in as well.
I'll go first, Chris, if you want. I think the challenge is always welcome, and the whole point really of a consultation is to gather the views of people, irrespective of how diverse they are. I have a different view. I'm an absolute firm believer in trying to care for people and give them the support in the least intensive setting. So actually, I personally don't believe it's a retrograde step to look at a community-based model of support. And if in the future there is a significant rise in the number of people requiring inpatient care, then I actually do believe we would deal with that and respond appropriately. So I personally don't have any concerns about that. But the devil's always in the detail, and the consultation will tease out all of those emergent issues. And decisions at the end of the day about how you deliver services are based on a myriad of factors, and all will have to be taken into account. And that's what we're trying. That's what we're trying and will do during the consultation. So over to you, Chris.
Yeah, thank you. Yeah, really helpful. And again, I think a really good thought-provoking challenge there in terms of what we need to think about as we go into consultation and tease out with people. But just to pick up a couple of points there, the piece around step down, absolutely. But that is the purpose of the community rehab team, because until recently, there has been a bit of a cliff edge that you come out of a 24-hour inpatient care, and after that we can offer a community mental health team popping in once a week, once a fortnight, and it's been difficult to do that transition for people into the community, and then the people have stayed in hospital longer than they really need to. The community rehab is that providing that step and transition, so there isn't a cliff edge, and it needs to be probably considered in a wider context of the work we're doing around the community mental health transformation. Is that there's been a significant amount of investment through local authority and health college combined to create capacity in community to develop those networks, and that continues to grow at scale. And that is some brilliant work going off in that space in terms of creating opportunities for people to create care networks and social networks in their own communities. So we are trying to put in that step, and that's what this work is predominantly about. The piece around demand, absolutely take the challenge on that. And when you look at the numbers here and now in terms of bed occupancy and growing population in that context, is something we do really need to reflect on. Equally, what I would say is that we don't have a county-wide community rehab service, and what we've seen, particularly in Grantham, Lincoln and Gainsborough, is where that's in place, the need for inpatient admissions are less. And why what we all believe, and again, we just need to stress test this through the process, is that as we expand that service to a county-wide provision, that'll have an equal impact in Boston and the surrounding areas and the other parts of the county not currently covered, which will mean that there'll be less people potentially needing admission to Maple Lodge. And I'm confident that because of the community rehab staff that have said and know the patients that are in Maple Lodge are saying, actually, we think we could support them. If we had the right housing and different bits in place, we think we could support a number of those people in the community. So I'm a firm believer that if we put in the community rehab service county-wide, what we'll see is the occupancy level of Maple Lodge coming down a bit, which gives us some opportunities for future growth. As Andy said, absolutely, if we get to a point where there are not enough beds, I'll be the first person to be raising my hand and saying we need to think about doing something differently to keep people appropriately cared for in Lincolnshire. So, and just to, I know it's referenced, it's not specific to this particular item, is that Ashley House and the use of Ashley House is it's currently being used as Sarah said. We just got an ask from a local care home that had patients or residents that were living in a residential setting and they had problems with their heating system. We proposed and offered to support them at Ashley House, let them use the building whilst their repair work went on. Just to say that Ashley House, one of the things that's made us drive the decision around Ashley House versus Maple Lodge is Ashley House is not particularly brilliant for an inpatient environment. It doesn't comply with modern day practices around single sex segregation. It's a house more than a ward when you look at the actual unit itself. And so the point about the future use of Ashley House, it's not particularly brilliant for an inpatient environment, great for a residential, great for housing setup, but not necessarily for a modern healthcare setting. And just to finally say, as references, at the moment we have 2 patients that were previously that need male PQ care placed out of area. Not ideal. We're supporting them where we can. We're trying as hardest to support people on our local wards as where we possibly can, and that's stopping the number of people having to go out of area that might have done otherwise. But a couple of people are out at the minute. We're actively supporting and working with them, and we're trying to keep that to a minimum. But yeah, I just want to kind of reference that as well.
Councillor Smith, you'd like to come back just quickly?
Thank you, Chairman. Yeah, just a point of clarification. I certainly don't want anybody to be dependent on that service, but I think it's there for a reason, because it works. I take the point around it not being ideal in terms of CQC guidelines, etc. And I also take your point around if beds did increase, you would look to do something. I can't dispute that you'd look to do something. What I can say is history says otherwise, that money talks, and things aren't going to go down in costs, they're only going to go up. So land will only increase in cost, bricks and mortar will only increase in costs. And there's an issue of resource now. So come however many years later, and I predict it will be an issue, because we're expected to grow how we're expected to grow across central Lincolnshire, which is East Lindsey, West Lindsey and Lincoln and the other district councils. You could end up with a big problem. And I don't know how you're going to solve it, which is why I've said what I've said. I take the point that it's a difference of opinion, but I just wanted to clarify that point. Thank you, Chairman.
Thank you. Just before you respond, I'd just like to add on to that. Do you feel that neighbouring trusts would have the capacity that, should there become a problem that there isn't enough bed for Lincolnshire patients, that they would be in a position to take them on in the scenario that Councillor Smith's outlined, where perhaps other neighbouring authorities are facing problems as well?
Yeah, I'm happy to pick this up. Absolutely. To be honest, I don't ever envisage that being a problem because of the nature of the level of need that we're talking about. But the people that currently access Maple Lodge and we're accessing Ashley House, there is bed availability. The type of patients that other units would probably quite like to have, because they're quite a good stage of treatment where you can really see the therapeutic benefit and people improving and maximising independence. So I'm confident there would be beds available, but I'm also confident we wouldn't need to use them.
Thank you. In which case, I've got Councillor Woodliff next, please.
Thank you, Chairman. I apologise, by the way, for being late. I had to park in Lucy Tower, fortunately. Good morning, Sarah, Chris and Andy. I've got 3 questions. Does this closure imply that Maple Lodge will also eventually close on the same principle of transferring everything into community? That's the first one. The second is, what saving financially is made by the closure of the buildings? There must be a saving somewhere along the line, otherwise you probably wouldn't be doing it. And the third one, I wrote it down somewhere, yes. Sometimes the issues creating the problem arise from the very conditions that people live in. And mental health issues are often very closely associated with deprivation. So sometimes it's not possible to treat people in the conditions that they live in, because the conditions are the conditions create the situations of the mental health problem. And deprivation is a very serious issue in certain parts of the UK, but particularly in areas on the coast, I think, Boston, Skegness and so on. Very serious issues there. So I'm not convinced that treating people in the community is necessarily as successful as people suggest, because the very cause of the problems is the issues, creates the issues, is in the place where they live. So if you can't change the place where they live, you can't really treat the issue. So removing people sometimes from those conditions must be the best option. So they're the 3 questions. Thank you, Chairman.
Do you want me to kick off, colleagues, and then come in? So I'll take each of them in turn. Thank you for the comments and questions. So Maple Lodge, that really great question, and we'll continue, as we always do, to try and make sure that people are treated in their communities as much as possible where it makes sense to do. But there's certainly no imminent plans around Maple Lodge. Back to Chris's earlier point about ensuring we've got sufficient bed capacity. But I look with interest in terms of the efficacy of the community rehabilitation model, in terms of and also our community transformation model and how that's building community assets and that support for people with their families and carers. So it's one for part of that sort of 5-10 year longer modelling work. In terms of the saving, it's 33,000. So this is not a financially driven decision. This is about making the most of what resources we can in terms of recruitment challenges. And as part of the mental health investment standard, any saving has to get reinvested into service. That's part of the national NHS guidelines around mental health investment. And a really great challenge around your third point around deprivation. That's why part of the community transformation model is about working with supported housing providers. And people won't get discharged if they haven't got somewhere safe to move on to. But it's very much part of the model to make sure. We often talk about it in terms of our alliance, you know, keeping people well isn't about secondary care services. It's actually about, do they have somewhere safe and warm to live? Do they have meaningful employment, not necessarily paid employment, education, volunteering opportunities? And do they have meaningful relationships within their community? So that's absolutely part of the holistic, personalised support model that we are able to provide through community transformation. So I don't know, Chris or Andy, if you want to add to that.
Yeah, I'm quite happy to add to that. I mean, it is a very good point about, you know, the implication, will Maple Lodge close? I mean, I can say that we've never had that conversation. It's not been a feature of any of these discussions about the possibility of closing Maple Lodge. But common sense would dictate that if at some point in the future, that might be 5 years, 10 years or never, the demand for services such as those provided in Maple Lodge has reduced to such a point that it's actually not required. But it's not been a feature of our discussion so far. To reiterate what Sarah said about savings, saving money has never been a feature of this proposal. I know that quite often decisions made about the delivery of services financially driven, but I can assure you that that is absolutely not the case here. And thirdly, you're absolutely right about the socio-economic status of individuals and the effect on their mental health. And that's why we're doing so much work with GPs and primary care networks about population health management. I think as we speak, there is a joint accommodation strategy meeting where the NHS and the local authority come together to work hand in glove to look at solutions for people who have need, particularly mental health needs, so everybody has their own front door. So we try and tackle from our end the bits we can, and we are getting much better as time progresses, as working as partners in the true sense of the word with the local authority, with district councils, with voluntary sector, and all of those elements of life that can come together to help change a community or a space that somebody lives in. So lots to do, but you're absolutely right, Councillor Woodliff, about people's place, and sometimes it is better if they're removed, but we have to ensure that what they go back to is not what they came from. So I don't know if you've got anything, Chris, or whether we're
yeah,
doing.
I mean, I think I'll just add on that particular point is, you know, it's absolutely right. It's for some people, you can't deliver effective care and treatment in the environment because the environment is a contributing factor to what they have. And I've worked in mental health services for many years and drug and alcohol services as well, where that issue is live, isn't it? Sometimes you have to be taken out of the environment to be able to get effective treatment, but equally, at some point you have to go back, and you need to be able to live well in that environment. And so that's really the role of community rehab. There are inpatient services for those that need to be taken away and cared for in a different place. But community rehab is about transitioning back to be able to continue those skills and that learning and be able to function effectively in the environment that you're going to go on and continue to live in. So absolutely the point is right, but that's, you know, that what we're trying to build is a range of options, both from inpatient settings where people can be more secure and safe, right into self-help in the community and everything in between. And community rehab, we feel, is a really important part of that.
Okay, thank you. I've now got Councillor Parkin.
Yeah, thank you. Hello, it's a really interesting debate actually. And I kind of just want to shift the focus a little bit because what we seem to be asking questions and making assumptions that people are actually able to access the services to start with. And so I almost want to turn the clock back and actually look at I completely support the proposal for more community care for people with mental health. I absolutely know that that is intrinsically the right thing to do. I recognise that we're right in saying that sometimes people's environments don't support that, but where they do, we should take a strength-based model, and where we have strength within people's networks and families and home situation, that's the building blocks for recovery. That really, really is. It's not something that's external, it's something that's intrinsic, and we need to use that strength. And I think that's where the power of recovery really rests. But I'm looking at it as we sit now with, people's access to GPs. We've talked about we've talked about deprivation, people's income falling, and how confident can we be that those front doors for people accessing the services are there and robust? Because my concern is that we are dealing with people with high-end mental health needs because they haven't had the early help. And that's my concern. How are we investing money, time, care, thought into those services? And that may not be a question for the people here today. That may be something that we as a committee need to start looking at, but it's the access that really bothers me.
Would you like me to go first? Quite
Yeah,
happy to. That's a very valid point, and I do welcome your support. And particularly, we agree, about the strength that's required for recovery and that model. I think you've touched on our main focus of how we want services to develop in the future. I think there's no denying that historically mental health services in the round have been underfunded, and access to mental health services has been limited by the capacity of the clinical teams. But over the last 3 years, I would say, we have seen, thankfully, significant and increasing amounts of money coming into mental health services. And you'll hear talk about paritative esteem, which basically says people with a mental health condition should have the same level of access and support and quality that people with a physical health condition should have. And we hold on to that as a sort of benchmark that we need to get to. The mental health transformation programme that we keep alluding to is a national programme, and some of you may be familiar with the fact that Lincolnshire was one of 12 systems in the country to be invited to bid for money way back in 2019, which saw us gain significant advantage over many other areas of the country to start investing, particularly in community. And we have invested and will continue to invest significant amounts of money in voluntary sector and community-based services that begin to and are actually supporting people with what we would call low-level mental health issues or mental health and well-being issues that haven't yet tipped into a medical system where they've got a diagnosis and are therefore labelled, haven't tipped into a situation where they become reliant on medication or see their health and well-being deteriorating. And we've got some really brilliant examples of how people are accessing all of those new community and voluntary sector-based services that, if you went back 5 years or 10 years, would have just continued to deteriorate and tip into lifelong mental health care, who are now surviving. So we're almost trying to turn the historical approach on its head. Prevention, intervention, wrapping services around people in their own communities, making communities resilient. And maybe the committee do need to have a greater line of sight of what that mental health transformation programme is doing, because it is impressive, in my opinion, and it is really making a difference to people in their communities and stopping them shifting into a medical-based model of care. So that's my response, and I'll let Sarah or Chris come in if they feel they need to.
Yeah, just to add to that, I think in terms of access, it's, as Andy said, it's really important. That's something we've been really working hard to get right, and there's obviously still more to do. But just as a bit of a summary of some of the things that we've built in certainly over the last 2 to 3 years, is we've got our Steps to Change talking therapist service that's got walk-in open access. People can self-refer directly to that without going through the GP, just to try to make that easy to access. We've got a helpline that's now set up so that people can just ring directly, and that'll navigate people into either crisis support if it's needed, or into other forms of community support and mental health services. We've just launched today it's called Hey Lincolnshire, which is How Are You Lincolnshire. It's a website. If you have a Google, it should come up. And that's a directory of services all designed to support people. You can search by borough councils in terms of where you live, so that you can access the support and see what's out there. And that's in conjunction with the Connect to Support helplines. We're working with the local authority of that, so we've got a really robust offer there with access specific for people with mental health and wellbeing issues. And we've got integrated place-based teams now as part of that community mental health transformation that Andy just spoke about, that are aligned to GP practices and PCNs. So we're still recruiting to those. That's some of the areas where they're not fully formed, but they're really rolling out now. We've got real good access building in the community. So there's professionals, community connectors, and then wrapping around all that, we've got all this investment of over £1 million now in per year in setting up community support groups across the county, so that there's opportunities for people to access self-care and then get into support where they need it. And there's a whole range of other things around that. We've also brought on our new mental health urgent assessment centre at Lincoln. I think we may have spoken to the committee about that before. That's got direct access for police, EMAS, and for other professionals, including the A&E departments, but also now opened up for walking. So if people are really struggling, there's somewhere to go. And then connected to that is what we call our nightlight cafes, our crisis cafes, that are all over the county now. They're popping up all over. It's kind of just seems to be just developing every day, where people can access some support in the communities, and then our crisis teams are linked to that, the urgent assessment centres linked to that, our community teams are linked to that. So we are really developing this network of support to make access as easy as possible, and then once you're in, it's a no wrong door principle that you'll be navigated and supported to the appropriate care and treatment. So really pleased with how that's developing. Really seems to have got to a tipping point in the county where there's something to be really proud of, but always more to do.
Yeah, Chairman, I think it's really interesting hearing that. Can I just say, from experience of a close family member, I just want to sing the praises of Steps to Change. It has been superb, and the amount of time and care that the councillors give is second to none, and I really do rate that as a service. I think a lot of the concerns that have been raised in the chamber, and it's just something that's clicked as we've been talking, is that unless you actually know, then this closure of Ashley House probably seems a little bit out of context. And I actually think an awful lot of the concerns that we have about that might actually be mitigated if we have more detail about how that service, how it all fits in together as a jigsaw.
Yeah, thank you, Councillor Parker. And it's certainly something we can look at bringing forward. I think it's important to know. I mean, I've got an individual case where I know that they're not having the same luck as you are. It's been through crisis team, been referred Steps to Change, heard nothing, gone back into crisis team because they've dropped off so substantially, to go back into Steps to Change, and again, nothing. And the systems don't join up. We've been told by crisis our system doesn't work. With this one, this is the situation. So I think the holistic approach of looking at this is important, because that is your feed in to where we are here. But I do think that, as you've said, this seems to be the right way to move forward. I've got Councillor Matthews, then I've got Councillor Thompson and Councillor Wootton, but I do want to wrap it up. So Councillor Thompson's dropping out because I'm just conscious of the time. So Councillor Matthews.
Thank you very much, Chair, and thank you very much, Andy and Christopher for the really good news stories. Made me feel all warm and cuddly that you're having such success. Sadly, I can report that that's not the case in Mablethorpe, and I want to just read you something that I've had from one of my ward members about her reactions to living in this. And just to contextualise my feelings about this, this is following up the 10 suicides that came around the nub of the GP practice that this person is going to be referring to. They weren't put down as mental health suicides, they were put down as drugs overdose or death by drowning or death by misadventure. And actually mental health didn't appear in their coroner's report at all, which is really sad. However, quite understandable. So this is what this person says. And first, can I apologise to the committee and to the professionals? I may use the wrong language. It's because I'm not a trained mental health professional. As a patient's first point of contact with NHS asking for help, no immediate help is given. They may prescribe a drug, but no counselling or therapy is given, nor is any contact information given to reach out to other groups, charities for instant help. This is also consistent when asking for help when self-referring after the return of persistent or reoccurring mental health issues. It's assumed that the patient knows what to do, whom to contact, etc. Antidepressants are far too easily described. Antidepressants are not monitored for side effects. Patient wait time is far too long between initial contact with GP to first therapy session. 6 to 8 weeks is usually minimal. The crisis team have little help to offer. They calm the patient and then send them home. Lincoln is the closest. Last time I took someone to use this service, we tried Louth first. The only other closest instant help group charity is Mind at Grimsby or Hull. Windsor House at Louth do not allow it. I'm going to stop because I think you've got the gist of it.
Councillor
This
Matthews,
is not me saying this.
Councillor Matthews,
This is somebody who's chosen
just
to...
one second, if I may. We are covering most of what you're raising within our working group that's meeting again next Wednesday. So it may be worthwhile us having that fed into that as well.
I will refer that into the working group. The point is, in terms of Ashley House, I think the closure probably is correct. I don't think it's an appropriate service and it is tying up resources, and I don't think it fits into our modern lifestyle. I absolutely agree with the response saying that, but they're closing it on the basis there is a good alternative community provision existing, and that's going to be extended into areas where it doesn't exist. And what I'm saying is, please, can we go back and look at that premise that the existing provision is fit and competent for purpose as an argument to close Ashley House? I don't think that's an argument that fits. I think it's a nuanced argument. The closure of Ashley House is probably appropriate, but the community service is the fact that it's allegedly good is not right. Thank you very much, Chair, for indulging me.
Sorry, go on, Chris.
Yeah, I just wanted to say, maybe I've come across quite enthusiastic in my telling of the developments that are going off around, community capacity building and community transformation, and I think rightly so. But that's not to say that things aren't great everywhere, because they're not. People have to wait for treatment at times. This is not great. We know that we hear accounts of people's experience isn't great, and so this is, a journey rather than the destination. Is that there's lots of work to do, but some of the things we're talking about are really new. The here, how are you service that's launching. It's this week. It's just launched. It's showing people what can access in the local areas. The nightlight crisis cafes are new. They're popping up all over the place, and I need to check whether they've got one in Mablethorpe. But that's the ambition, to have them everywhere, and so. But the pace at which that's moving is really optimistic, I would say, in terms of offering that support. And the community asset fund that's been launched, it's just live now. That's about just less than £1.5 million been spent on promoting, enabling community groups, and that's been weighted in terms of distribution of resources to those areas that are most deprived. So I would anticipate some of the areas up the East Coast would benefit from that. So there are things in place and things to be done, but I don't want you to think that I'm sitting here saying that it's wonderful everywhere, because we know it's not, and that's why we're investing so much time and effort into trying to make this better.
Okay, thank you. Councillor Underwood.
Thank you, Chairman. Mental health is a very complex issue, and it's very much in vogue at the moment. You gave us a lot of information on the paperwork, and I thank you for that. But you quoted on page 29 the year 2019 to 21 regarding Ashley House. This was a COVID period time, and I think there was a case of trying to keep people out of hospital at that time. 52 people were mentioned, and they came from all over Lincolnshire to Ashley House, or within that unit at that time. 2/3 of them were looked after out in the community with the community rehabilitation team, but that still leaves 1/3 that had a need. So I assume that the third of people would still be hospitalised, or whether it's going to be in a place like Ashley House or another equivalent in Lincoln. I think the important thing that we need to realise is that it is a loss of 15 beds. And my colleagues, I think, have come up with some excellent questions, and we've retrieved that from the paperwork. Chris mentioned at one stage that people will be looked after in their homes, and I think Councillor Allen brought up that not everybody has that pleasure or privilege to be looked after by their family or in home. So, and you said the other percentage were looked after would be in the community. So are you saying to us that these are people that have had mental issues all through their life, and they're supported in supported housing? I'd just like you to answer those questions for me. And I think there is a push for more people to be working more in the community to rehabilitate people. I see the vision, but hopefully you'll take on board what we've said here today. And I believe one of the gentlemen acknowledged that there are problems, and it's not all good, and it doesn't always work. And people in the community will be covering a wider area, is my understanding, because only a certain amount of the area is covered at the moment. And if you've got these people going out all over Lincolnshire, that's a good thing. But as you've said, they'll be working 8 to 8, and people do get into crisis, and they do have a need beyond these hours. Thank you, Chairman.
Thank you, Councillor. I'm happy to start, and if anybody wants to add in, that's fine. So just to pick up that, absolutely, the unit originally temporarily closed during COVID. It was due to staffing pressures and a number of pressures, and that's kind of what instigated the change. But as we've made that change, that's what we're talking about here today. It's proved to be really successful, and we've seen, or we believe it's been successful, and that's what we need to test out through the consultation. Your comments about the number of admissions is accurate. About a third of those that were in Ashley House before, around about that, would still need some sort of inpatient admission and inpatient support, and that's now provided at Maple Lodge, and we've been able to create that capacity because people that would otherwise be admitted to Maple Lodge are also being supported in the community. So if you think about that being applied across those two units, if only a third from each unit needs admission in the future, then the unit will only be 2/3 full. So that's the ambition really in terms of where we're aiming to. And just the point about the ongoing support and people's own homes, maybe I should explain that a bit more clearly. When I talk about people's own homes, I mean wherever home means to the person. Sometimes that might be living in an independent house, living with a family, or it might be living in a residential setting, but it's where somebody's going to be to live and where they call their home and residence. And I think that what the community rehab team does is support people to maximise the independence for that individual and maximise their life chances. And so ideally we want people to live independent lives like the people who are around this room screen today, in living and working and contributing to society and getting a fulfilling life. And that's what we want from everybody. Some people might be more restricted in what they can achieve, and if that means that they have to be in a supported environment to do that in a residential setting, then absolutely we'll support them within there, but always looking to see what we can do to maximise people's life potential and life outcomes. So sorry, I maybe should have articulated that a bit more clearly earlier.
Okay, thank you. I've just got two questions myself, and then I'm going to move to a proposal. So, what is the view from those staff who are currently redeployed elsewhere within the Trust regarding the preferred option of closing Ashley House? And if these staff decide to move on, what impact will this have on the expansion of the community rehabilitation model?
I'm happy to pick that up. Just what we've found, and I think it's within the documentation there, is that what we've found is that the people that have been redeployed pretty much really enjoyed the work that they're doing and have wanted to continue to stay in community rehab, and that will potentially cause us as an issue and a bit of a delay if we do decide to reopen Ashley House, because those staff have gone on and found that they've really enjoyed that community way of working. And so if we did reopen Ashley House, we'd have to do a review of the workforce and how we staff that back up. But absolutely, they've stayed within the organisation. I don't think I'm not aware people have left the organisation, have stayed and they've moved into either the community rehab team or other community services. They're really and seem really satisfied with that, is my understanding.
Okay, thank you. And my final question is, do you have any plans you can share about the future of Ashley House Lodge site at all?
Again, I'm happy to come in there. Is that at the moment, no, I suppose we're waiting the outcome of the consultation. Should the outcome of the consultation mean we move to a permanent closure, it does create options and opportunities around Ashley House. There's, as I said before, it's currently being used as a residential home, so it does lend itself to that type of care and support. I know we've had conversations with local authority and other system colleagues about housing opportunities for people with mental health difficulties and others. And at the moment, Ashley House has not been able to be explored in any detail because of the current temporary status. But if we did move to a permanent closure, then absolutely that would open that up to a further exploration around those ideas.
Thank you. In which case, I'm going to propose that we note the consultation on the proposed service change at Ashley House and Grantham, and to agree that a draft response is prepared for the committee to approve at its next meeting on the 15th of February, based on the committee's comments at this meeting. Do I have a seconder to my proposal? Thank you, Councillor Haigh. All those in favour, please show. That's supported unanimously. Thank you. And thank you to our presenters.
Thank you. Thank you very much.
Thank you.
Thank you.
We'll now move on to agenda item 6, North West Anglia NHS Foundation Trust's restoration, recovery, update and the progress of the clinical strategy for Stamford Hospital. This item was circulated as part of the agenda pack on pages 43 to 51, and I would like to welcome our presenter via Teams, Caroline Walker, Chief Executive of North West Anglia NHS Foundation Trust. I'll hand over to you just to go through the report. I'll take it that it's as read, but anything you'd like to update and questions at the end. Thank you.
Thank you, Councillor. Thank you for inviting me to your committee. It's good to be here and back with you. I'm here to present the report with the focus on the recovery and the strategy for the Stamford Hospital site in the heart of South Lincolnshire. So I will take the report as read and re-emphasise a few points for you before taking questions, if that's okay with everybody. So a large part of our activity is Lincolnshire residents, as you're well aware. The paper articulates that through you from the beginning, and Lincolnshire residents and population play a big part in our plans and our delivery. The report focuses on the planned care delivery and waiting time reduction, which has been an agenda for the Trust over the current year since recovering from the pandemic. But it would be timely also to say that that has been affected by our urgent care pressures. I'm going to focus on the planned care, but given the pressures that the NHS is under at the moment in the heart and the thick of winter, our plans have been affected by pressures of winter and urgent care. Impact on elective and planned care activity as well. So post-pandemic, the whole NHS has responded the same. The ask for 22-23 was to bounce back and to deliver activity in line with 1920, the year before the pandemic, and where possible aim to do 130% of activity from previous levels to get the waiting list reduced that had built up during the pandemic. And we were given 2 years to do that into 24, 25. The Stamford Hospital plays a big part in that. Stamford Hospital is a planned care site. It doesn't have any emergency services other than a walk-in minor injuries unit. So we have done more and more activity through the Stamford site as we've gone through the last year. Our deliveries include lots of digital solutions as articulated in the paper, and lots of pathway changes as well, where we've tried to add some innovation and do things. And something called patient-initiated follow-ups are also part of our recovery, because our waiting list isn't just about patients for planned care and surgical procedures and operations. It's also about people waiting for planned care that is outpatient related or day case procedure related as well. Some of the changes we've made have included primary care picking up some of the activity that might have previously been done in acute hospitals to either avoid admissions or to review referrals or to test people and screen people before they come to appear on our waiting list. So hopefully that is something that you're familiar with as part of the package of innovation and change that the NHS is making, and lots of digital solutions where patients don't have to come to the hospital site as part of receiving their first initiated contact with the hospital. We've used the independent sector a lot, and we've definitely done some insourcing, which is where the independent sector come to the hospital and use our facilities, but private clinicians and private staff deliver the activity at weekends and evenings for us, in addition to what we're doing during the working days. And just to make the point that we've reduced our waiting list and delivered our elective plans based on the clinical need. So our clinically urgent patients have been done as a priority, and now we're focusing on the longer waits within that. We're also faced with increased referrals. I'm not sure that comes out so explicitly within the paper. Some of our specialties have had a 38% increase in referrals over the last year, which possibly is a catch up from pandemic lower referrals, but possibly a function of where some of our population growth is and where our primary care practitioners are referring urgently because of big waiting times in our planned other procedures. Our recovery has also involved supporting our staff as well as recovering our waiting list and reducing our waiting times. So be reassured that we're supporting our staff during this period as well. So that's hopefully clear in the paper what we've done about recovery. Our waiting times and our waiting list is coming down. We've got lots more to do. It was a 2-year plan, and we're focused at the moment on reducing particularly our cancer waiting times and our very long waits at 78 weeks as we go into the last quarter of the year. The report also articulates, as requested, the update on the Stamford Hospital site. Stamford Hospital redevelopment is at the heart of NWAF's strategy and still plays a big and important role in everything that we do. I think I articulated the big slice of our population and our patients that do come from the Lincolnshire localities. Our clinical strategy from Stamford and Vision is articulated in the paper. We intend to do more and more planned care there, more and more outpatients and procedures that don't require general anaesthetic. And we've got some plans to do some more one-stop shop type things where you come for your first outpatient attendance and then you have a mini procedure if, based on that consultation, it's deemed that you need to go on for some treatment, which we're doing for ophthalmology and ENT and plastic type procedures as well. So we plan to increase services on the site for outpatients and diagnostics and day cases. At the moment, we're reviewing whether we need more beds on that site, but I'm not sure that we do. And we're also planning on the site to do more clinical education and do more training of our workforce as we go into the next 5 years. So I'm happy to take questions on any of those items. Hopefully a little bit more is explained within the paper, and hopefully I've managed to give you just a quick overview of where we're at with our recovery and our strategy for the Stamford Hospital site. Thank you, Councillor.
Thank you. Councillor Allen.
Thank you, Chairman, and thank you to our presenter. I've got some. I must acknowledge first of all that we're only being asked to note this report, and that's understandable, bearing in mind that it's outside our area. Although it was interesting to see that 20% of our of their patients do come from Lincolnshire, which is quite considerable. I've got some comments, and I'm concentrating on part 2 of the report because I'm not totally sure we've had one from ULHT yet in terms of the recovery and restoration post-pandemic. I think I've asked for it in the past, and I haven't necessarily seen anything that's obviously a report that says how they're actually going to deal with all the issues that have come from that, Chairman. I hope we will do soon. So my comments are very much relating to something of a similar sort of nature that might come out of the trust that we're most heavily involved in terms of scrutinising. So perhaps the comments could relate to that whenever they arrive. Item 2 says route to full restoration of the services. That's fine. We do need to get back to where we were pre-pandemic, but what worries me is it has to be more than that. I mean, we need an enhancement to the ability of the NHS to deal with the consequences of the pandemic, not simply get back to where we were pre-pandemic, because of the significant amount of people that we've got on the waiting list waiting for various forms of treatment, some quite serious. And I'll come back to those as we move through the through item 2 on the report. And I struggle to see from everything that I read and everything that I see what it is that's going to happen to actually reduce the waiting lists in a foreseeable period of time, apart from just waiting for people to die and then remove them off the waiting list as a consequence of that. So I would like to have seen something that says, and above and beyond the restoration and recovery of services to the pre-pandemic level, this is how we're actually going to start tackling the waiting lists that apply in our trust area. I'd like some sort of comment, if at all possible, on 2.1 in terms of the use of the independent sector, because that does seem to be something that could be used to actually tackle waiting lists and produce the additional capacity that we have. It's very unfortunate that we privatised the independent sector to all intents and purposes during the pandemic and never used them at a vast cost to the economy. And there does seem, from what I see, a reluctance to use the independent sector to actually help deliver the backlogs. So any comments that can explain that would be very useful. I find the graph at 2.3 very hard to make much use of because it's to do with demand, which is referrals in NHS terms. But it hasn't got very much information pre-pandemic, so we're meant to be comparing the situation pre-pandemic with the post-pandemic situation, although I have no idea what the demand was from the graph in the pre-pandemic situation. And it does seem to me that since hospitals have started to open up, the demand stroke referrals seems to be fairly consistent. And you would expect it to be increasing, perhaps, if you're trying to tackle the backlog. So does that mean that demand and referrals have been limited by the ability of the service to actually provide resolution of that? In other words, we can only provide a certain level of service, irrespective of what the demand might actually be. And the waiting list, which is being put forward in the report as something of a positive nature, does strike me as being a fairly minor one to a certain extent, 540 to 500 or so reductions. It does seem as though, and I'd like to know whether these are people that have been treated, because it does say clinical exception or patient choice, and I'm not totally sure whether death is a patient choice or not in terms of removing itself from the actual waiting list, and I'm not totally sure whether clinical exception means it's too late to actually do any treatment. So maybe that could be clarified. And of course, the major situation post-pandemic with people coming forward for referrals for treatment that they should have had over the past 2 years won't appear in this graph at all. And arguably, people are going on to the waiting list at 10 weeks or 12 weeks or 20 weeks, which arguably have got, should have been on the waiting list a year or even 2 years ago, and would appear in this list had they done so. So a number of issues, but it's more, I think, to ensure that we get the right information as and when we get the bigger restoration recovery plan from our own trust.
Councillors, would you like me to attempt to cover most of those items? I'll be general on some of them and specific on others. So I want to reassure the committee that we did use the independent sector during the pandemic extensively, and we do continue to use the independent sector to supplement and add to our capacity. Some of that is directly when we refer our patients there, and some of that is when patients are referred by the GP directly to the independent sector. So it is part of the restoration of the whole NHS that the independent sector is used. And then we're also using the independent sector by asking teams of private providers to come into our hospitals to deliver at the weekends, as I said. So there is a combination, and it is supplementing NHS activity that is at capacity at times. So our referrals have increased. You make some good points there about the slide not necessarily making it obvious, but our referrals have increased, and some of that is because they did reduce during the pandemic, but also some of that's because of population growth and other things making those referrals. It's not all pandemic related. That waiting list that's increased, so there have been increased referrals, and we've taken those referrals, and our waiting list has increased. So whilst we've shown that our long waiting times in the table at 2.4 have reduced, our overall waiting list has increased during the last 2 years as a combination of increased referrals and the fact that we've treated less patients as we've reduced our productivity in the post-COVID environment as well. So clinical exception is a particular phrase we use, and that doesn't mean that a patient's passed away. It means that they're not ready for surgery potentially, or they've got other things that they need to do before surgery, and they're not fit for surgery, etc. So when we say clinical exception, that means that they're no longer active on the waiting list because they might have even chosen not to have the operation that they were waiting for, as in patient choice and things. And some people on our waiting list have, in the meantime, while they've been waiting a long time, elected themselves to pay privately for some of the procedures that they might want to do as well. So there's a combination of things that, as well as treating the patients on that slide at 2.4, that have reduced our waiting list during that time. So I think within all of that, there's an articulation that the plans are a combination of things. They're a combination of doing things differently, but also doing more and reducing I'm confident that we've got the right amount of capacity to treat our patients as they're referred, but what we've got to do is have some additionality to treat our patients that are waiting, because the waiting list has built up over the last 2 years, and we haven't since in the last year managed to get that reduction back down to normal levels where we can cope. And it's not every specialty. There's about four clinical areas that our biggest waits are within that. So it's a combination of factors that are reflected in this position. Thank you. I think that covers most of the issues raised.
I'll allow you to come back briefly, please, Councillor Allen.
I've turned it off. Sorry, I've turned it back on there. Very briefly, Chairman. Thank you very much for the response. It hasn't really given me a great deal of comfort, to be honest. I would like something in terms of a restoration and recovery plan that shows how capacity is going to be increased, and if the independent sector has got a part to play there, perhaps that ought to be concentrated on in terms of proportions, because it strikes me that one of the issues that we've got is that we know there is a demand out there, and the demand is being rationed to a certain extent to match the capacity that the National Health Service has an ability to actually deliver, and it must increase that capacity if it's going to deal with this backlog. And I'm not really expecting a response, Chairman.
Okay, thank you. I've got Liz Ball next, please.
Thank you, and thank you for the paper. From a Health Watch perspective, I was just really keen around the developments at Stamford and the timeline and the progress on those, because it's really nice to see that there is going to be some new developments and some existing developments that are going to spend more days a week delivering those services. Thank you.
Thank you for the question. So, I mean, timelines are from now, actually. We are in the middle of knocking down buildings and putting new buildings up as we deliver the physical solution. I would say the strategy is a 2 to 3 year strategy. So to achieve the full vision as articulated in the paper is going to take us 2 to 3 years. We have some funding secured for some of the building works that are required, and we need to make the case for the further works as well. But some of the actions we're taking to change the clinical provision of outpatients or procedures on the site aren't linked necessarily to extra funding. They're about changing some of the site provision from the Peterborough site and utilising the Hinchinbrook and Peterborough sites differently, with more going to Stamford as well. So there's a combination, but it's a 2 to 3 year plan to deliver that strategy, and some of it's already in delivery. The builders are in knocking down buildings to allow us to build the new procedure rooms and theatres on that location. So money secured for some of it so far, but more to go.
Thank you. And just coming back to Councillor Allen, I did mean to say before we moved away that we have got ULHT here next month to discuss over these issues. They were meant to be here this month, but they're under immense pressure, and that's why they're not. And we were previously updated on the recovery plan in November of 21. Okay, I've got Councillor Cleaver next.
Thank you, Chairman. Thank you for the report. In relation to the minor injuries unit, in paragraph 4.5 of your report, sorry, not 4.5, 4.3, is the subtext to this that you are actually asking Lincolnshire ICB to make the MIU into a urgent treatment centre 12 hours a day, 7 days a week, because that is clearly the NHS model that is referred to in the paper that you mentioned, the urgent treatment centres principles and standards. Is that what you're actually asking the ICB to do? Presumably that would obviously provide a better service for the people who live close to Stamford Hospital, but also obviously take pressure off the A&E at Peterborough. And what progress have you had in those talks so far? On the question of the taking forward the clinical strategy, I'm a little bit confused between the relationship or interrelationship between your premises strategy as it stands now and the clinical strategy. The clinical strategy seems to be has been signed off actually for some time, hasn't it? Over a year now, and it's clearly laid out in the graphic in section 4.9. But then in section 4.6, you're talking about an initial focus on defining the options for the site. So I'd have thought the options for the site are already determined by the clinical strategy that you already have in place. So if you could just tell us exactly to what extent the vision of the clinical strategy is definitely going to go ahead. How much of it is actually secure, it will go ahead, it's absolutely committed to, and how much of it is still dependent upon decisions still to be taken in terms of the premises strategy. Finally, third question is on use of integrated IT with primary care. I know this is a constant topic of mine, but it is a concern that there are still paper forms flying around and that patients who are referred by primary care providers still have to print off their own forms at home and bring them in when they come into Stamford Hospital for tests. Do you have any plans to make the patient interface between primary care and yourselves paperless? Thank you.
Thank you. So the minor injuries unit is something that we're in conversations with the ICB. It's their decision as to what they want us to do as the commissioner of that service. The whole of the NHS has decided that minor injuries units shouldn't exist from April. They should be urgent treatment centres, which are enhanced beyond what is currently provided, because the minor injuries unit is a service that's 9 to 5, Monday to Friday, and the national mandate for UTCs is to have services 8 till 8, 7 days a week. So it would need an expansion, and that would need investment and money and extra staff. So we're at that point where we've got to do something as well. The attendances per day are only about 30 people at the Stamford Minor Injuries Unit. So the balancing act the commissioners and ourselves have got to understand is whether it's it's worth extending it to get more availability and to help offset some of the pressure on the Peterborough site, or does it not warrant that within that? So we're working with the commissioners, we're in open dialogue with them, and it's something that we've got to make our minds upon. But they've asked us to continue running a minor injuries unit on that site until we do make a different decision. It's not as if from April we're going to close it and say it's not a UTC. So be reassured of that within that. So hopefully that covers that one. Our clinical strategy was agreed over a year ago. We're still proceeding with that, and some of that can be delivered without a physical solution, but some of that does need physical investment and change to the site. And when we say we're still figuring out our strategy for the site, that you are right, that is the physical premises solution, which means how do we keep all of the services running and rebuild the new services and then switch off the old and knock them down and do various things. So when we're saying we're developing it, we're not changing anything about what we want to do clinically on that site. Indeed, we're wanting to push more and more clinical activity to that site. What we're saying is we've got to figure out how the best building solution is to make sure that we can keep the procedure rooms running and the theatre side of it and the outpatients running whilst building the new facilities, and then move into the new facilities and knock down and demolish the old building. So that's the bit I probably didn't make obvious from the paper, that the clinical strategy is fixed, being tweaked a little bit, but the physical practicalities of how you do things. And as I said, we have secured money for a large chunk of that, but not all of it yet. And the builders are in at the moment, knocking things down and levelling the site, ready for the new procedure rooms to be built. So that's that. The specific point on forms for blood tests, I wasn't aware of that, but we do have an integrated care record that we do share information between primary care and the hospital in Lincolnshire, and that's something that the whole of the NHS have had to do, share records between systems when you don't all have the same system. I will try and find out what the issue is about printing forms, if there's something specific about blood tests. People have spoken to me lots about blood tests and the queues at Stamford, and we've done lots to enhance that service there and put more capacity there, but people haven't mentioned actually paper forms and the IT interoperability issue for me linked to blood tests. So I will take that away and have a look at that for you, but I don't know the answer to that one. But we do have access to the records, and GPs have access to our records in summary form, as well as we have access to System 1, which is a system that the GPs use as well. So that is a good development that's happened in the last few years. Thank you.
Thank you. I've got Councillor Smith next.
Thank you, Chairman. Just 2 points. You mentioned you use the private sector on a weekend. What cost implications does that have for the trust? And the second point, I don't expect, and it's not something I need an answer to, but it's just to put on the record that it's, and this is not a slight at your trust specifically, it's the NHS that's having this issue in general. It is an indictment that some residents are having to go private because they've waited so long, and they're fortunate enough to afford that. There are a lot of our residents that don't have the option, and as Councillor Allen said, if things don't get sorted soon, we are going to have reports where people have been waiting for various operations, whatever they may be, and they die. That's not to put a fun point in the but that's what's going to happen. That's the cold light of day. So we need to do what we can do as a scrutiny body to try and work with colleagues to make sure that doesn't happen for obvious reasons, Chairman, but it's a very poor indictment that we've got to this stage. You know, they're paying national insurance the same as I am, the same as everybody else is, and what do they pay it for?
Let me respond to that second point. All of the patients on our waiting list have been reviewed for clinical urgency, and we have treated those most clinically urgent patients, as have all hospitals. So the people waiting on the waiting list are the ones that are clinically less urgent, and that's not something that patients often want to hear, but is the practical reality of their condition not being life-threatening or urgent. So, and they're the ones where we've got the long waiting times for those procedures. Within that. So sometimes individuals do make the choice to go privately when it's affecting their lifestyle, or if it's pain management, or affecting their ability to do physical exercise, etc. To some extent, the ones that are deemed to be less clinically urgent. And the first part of the question was about the private sector. We do pay the private sector. There are nationally negotiated rates for that within that, and it does add to our costs, but we don't have the physical capacity or the workforce to do all of the activities that's needed at the moment. So it is a welcome and necessary part of the recovery, in my view.
Okay, thank you. I've just got one question. I've got no further speakers. And my question is on paragraphs 4.5 and 4.8, it refers to the need for concrete remedial works at Stamford Hospital. How long is this likely to take?
So what we have since discovered is that the construction of the procedure rooms, the theatres bit of Stamford Hospital is made of this rack constructed concrete, which is defective. So we have been mandated to get out of that building, which is exactly why we've just knocked the nursing home and another building down so that we can build a new procedure room on top of it. So that's something that will be within the next 2 years that we get out of that building. We're in the process of securing the funding for continuing that. We've secured the funding for the demolition and clearing of the site, and then we will secure the responsibility. But we've definitely been mandated to exit any building that's constructed in that way across the whole of the NHS. Our entire Hinchinbrook Hospital is constructed of that concrete, and we are also mandated to rebuild completely the Hinchinbrook Hospital in the same way within that. So that's what those are referring to. Hopefully that covers that for you.
Yes, thank you. I don't envy the whole rebuilding of Hinchinbrook. I think that's going to be a massive cost. And of course, we'll be interested to see what update you can give us on that at a later stage. I think that's all the speakers now, so I'm going to move to the proposal, and that is that we note the report from North West Anglia NHS Foundation Trust, including the plans to reduce the number of patients waiting more than 78 weeks for treatment, that we request a copy of the Trust recovery plan and KPIs for the recovery plan, that we support the clinical strategy and vision for Stamford and Rutland Hospital, including increased chemotherapy, cataract surgery and ophthalmology clinics, and finally that we support the minor injuries unit becoming an urgent treatment centre at Stamford and Rutland Hospital. Do I have a seconder for that proposal? Thank you. That's seconded by Councillor Cleaver. All those in favour, please show. That's supported unanimously. Thank you. Thank you, Caroline. Thank you for your time today.
Thank you. Thank you for your time. Good to see you all.
And you.
Bye.
Bye. We'll now move on to agenda item 7, the Lincolnshire Dental Strategy. This item was circulated as part of the agenda pack on pages 53 to 60, and I'd like to welcome our presenters via Teams, Carol Pitcher, Senior Commissioning Manager for NHS England, Alan Reid, Consultant in Healthcare for Public Health NHS England, Sandra Williamson, Director for Health Inequalities and Regional Collaboration for the NHS Lincolnshire Integrated Care Board. If I can hand over to you for your PowerPoint presentation, and we'll take questions at the end. Thank you.
Thank you very much, Councillor. I'll start. So I'm Alan Reid. I'm a consultant in healthcare, public health. I'm just going to share my screen for some slide sets that I've got. Could you just let me know if you can see that okay?
We can, thank you.
That's brilliant. Thank you very much. So obviously, you know, the situation with dental commissioning and dental services and access in Lincolnshire is particularly challenged. This is a national problem following COVID and the recovery of services, much like for other health services. Is very much aware that Lincolnshire has its own particular problems of rurality and coastal areas, retaining and attracting dental workforce for that, a challenged environment, and then the East Midlands doesn't have a dental hospital to grow our own talent and retain our own talent. So a number of challenges that make Lincolnshire a particularly tough area for dental services following the impact of COVID. But actually, and we've been here before in terms of coming to the HOSC previously with my colleagues Carol from Dental Commissioning to give you updates and a plan of action for going forward. So really what I want to do is to perhaps talk about something a bit more optimistic that we're doing and positive that's happening now. I was asked to come in back to dental public health. I'm a dentist by background, worked in general public health and dental across both. So at the end of the year, with the coinciding of the delegation of dental commissioning from NHS regional, over to local integrated care boards. The Lincolnshire ICB wanted to develop a 3-year dental strategy that's local for Lincolnshire to take forward, to act as a roadmap for recovery and development of dental services going forward. So the paper that I've provided gives us an outline of the work done today, the kind of themes we're talking about in the strategy. So I'll just go forward with this slide set and just show you the general timeline. So this project of this dental strategy was really started towards the end of August, beginning of September, where we did some individual scoping conversations to develop the key strategic themes of the strategy, followed by in September with a number of online workshops where there was wide stakeholder engagement, and the approach we wanted to take was to think about, do a resource-based view of the strategy, to think about our local assets and resources and our capabilities and how to build on them and maximise that. And that's really taken away from, a deficiency view of the strategy, which we kind of felt was a negative way of going forward. It's really this shift of commissioning from regional to local to integrated care boards really gives an opportunity for really needs-based, place-based commissioning in Lincolnshire that we've never had before. So it's a real opportunity to think of the resources that we've got and how we can use them best. After the online workshops, we then had an in-person stakeholder workshop in Lincolnshire, which was really well attended by a wide range of stakeholders, which I'll show you in the next slide. The latest is that we've developed a draft strategy which is going around the houses for comment. That should be finalised over the next couple of weeks, and that will be signed off at the Integrated Care Board. And then after that, there'll be an implementation plan. Just thinking about the stakeholders, I mean, that's just the key ones there. We had wider ones, but you can see as well as NHS England Regional, and they're handing over responsibilities or delegating that commissioning to the Integrated Care Board. We also had, of course, the local authority, the Lincolnshire County Council, with their responsibility for improving oral health and the prevention element of the dental care pathway. We had really quite good engagement from the dental profession across all sectors, so general practice, the community dental sector, the corporate, the big multi-practice organisations, and also the private sector in dentistry, because although we know that dental contracts have been handed back in Lincolnshire from back to NHS as dentists move towards private, there's also a recognition that can go the other way, and if we get this strategy right and engage with the profession, there may be novel commissioning pathways that we can develop that takes activity back from private towards NHS. We also had wider in dental. We had whole pillars of primary care, general practice, pharmacy and optom, as well as health watch, of course, and patient representation. Another interesting and exciting stakeholder is the University of Lincolnshire and the academic partners we've got working there, working around developing a centre of dental development and thinking in their work around rurality and coastal areas and underserved communities, and doing research and evaluation work there. We also had Lincolnshire Cares Association working with our vulnerable groups and older adults, and also our voluntary community services involved. So really a broad range of stakeholders involved in developing this strategy. In terms of the methodology we used to do that, we used a logic model methodology, and I think that was quite new to people to get them thinking about, starting off thinking at the right-hand side, the kind of outcomes that we want to see and getting agreement in that, and then working backwards to think about what activities we need to do and what resources, inputs or structures need to be done and put in place to realise those outcomes. And I think that's an important point of this strategy and the engagement that we had. I mean, there's two ways of doing a strategy. It could be very high level, top up, that comes down from probably something that comes down from NHS regional. But really, we wanted to get people involved in this and think, collectively about the strategy. And this logic model really lends itself to that. Just an example of some of the outcomes. So one of the themes was prevention, as probably not a surprise. But you can see the long-term outcomes on the right-hand side, and then working back to think about the activities and the inputs that we want to see from that. it's important, obviously, that their strategy is aligned with national strategy, and of course, in terms of reducing health inequalities, which is a golden thread running through the whole strategy, is linking it to national NHS Core 20+5, and that's NHS national modular framework for reducing health inequalities, focusing on the most vulnerable groups and our place-based needs of our particular needs. So local in Lincolnshire, maybe older adults, people living in coastal areas. Just some of the key enablers of the strategy that was running through, as well as inequalities, is the use of data intelligence and really being needs-led and having knowledge and evidence and insight. So that's a key area that's running through that. The workforce and the engagement of the workforce is something that came through strongly in the work that we did with the strategy. So leadership and engagement and that collective can do, will do attitude, which I think, given the challenges of dental services over the past couple of years and prior to the pandemic as well, I think we've lost a lot of positivity there. And I think that's really important to bring that back. And then along with that, this culture change and really valuing and maximising the potential of the whole dental team, not just dentists, but the whole dental team, so dental nurses, dental care professionals, and other support staff as well. Just to give you a flavour of the workshop that we held for the strategy on the 30th of November, as I said, a wide range. You can see John Turner in the centre picture there, from who's Chief Accountable Officer for Lincolnshire Integrated Care Board. So really a lot of good energy in the room, and it's been well received. And I think it's galvanised a lot of and brought partners together in a way that perhaps was missing in Lincolnshire. So just in terms of what the strategy looks like on a page, you can see the 4 pillars there that we've got. One of the key ones is developing the dental workforce. That's one of the strongest ones. No matter, we can commission more dental services, but there's actually a lack of workforce and uptake for that. So that's the developing the dental workforce is the key aspect of the strategy, and really enriching the well-being and capability and engagement of the workforce. Obviously, another one is access to dental services, making sure that we're improving that access. We're using innovative ways in terms of commissioning and access improvement schemes, use of evidence and best practice, and most importantly, eliminating waste in dental pathways. We know there's still a lot of people accessing NHS dental care who actually have low risk of oral health and can actually go a bit longer without their 6 monthly checkups as well. So it's really about being smarter how we work. A step up of prevention, so we're working very closely with our local authority and their Oral Health Alliance group. And finally, integration of oral health, making sure that oral health doesn't sit in a silo in dental. It's integrated across other care pathways. So, for example, the frailty pathway, working with care homes, and just making sure that oral health is everyone's business across Lincolnshire. You can see the overall mission statement that Lincolnshire patients and the public at the heart of everything we do, and you can see those cross-cutting themes there: health inequalities, the best use of evidence, and enhancing leadership and improving that culture. So, as I said, the first draft of the strategy has done the rounds. It's been developed. It should be ready in the next couple of weeks to take forward. And the next steps of that strategy will be final sign-off, setting up an implementation group, and then developing an implementation and delivery plan. So that's an update of the strategy. I'll stop sharing my screen there. Bear with me. And I'll move on to, happy to take any questions, Carol and I, going forward with that. Thank you very much.
Okay, thank you. I've got Councillor White first, please.
Yes, I am concerned how you access those children and their parents who haven't been seen by a dentist. I mean, I've looked at some of the research that's been carried out, the National Dental Survey of 2019, and I think a lot of that was mathematical projections, because they hadn't been in all the local authorities. They only saw children whose parents gave consent, and in large schools they did random samples. I see there was an oral health need assessment in 2022, and I'd like to ask the question as how do you know that you saw all the children who hadn't seen dentists in that respect? So I see the strategy, but I still don't know how you're going to access all these children who haven't seen a dentist.
So in terms of the national survey of dental health, I mean, that does rely on a sample of children, because it's just impractical to do the survey across all children. So it does draw on a sample, and that's an accepted way. In terms of accessing children, all schools will receive, as part of the education, health education in schools, receive oral health instruction, and the oral health improvement team that's commissioned by the local authority do go out to schools in Lincolnshire and do supervised toothbrushing and give oral health promotion materials and advice. So although not all children take part in the survey, it's a sample, they do get information about oral health and oral health improvement, and information how to access that. And it comes to parents in many ways, so through health visiting as well, there'll be advice. And again, part of that strategy about integrating oral health into wider pathways, it already is in many ways. So there is work there, but the national programme of doing the survey, that's a national programme. It does rely on a sample method, and that's a statistically acceptable way of doing that.
Are you saying that all school children in Lincolnshire have got access to this information then? As far as health visitors are concerned, people in the community know that a lot of health visitors haven't done the usual assessments of children. So I'm still not convinced.
I would think it's fairly common knowledge that that all schools would do oral health improvement advice. It's in the education, health education for schools. Oral health is included in that as a mandatory aspect of that. So I think, and as to the oral health improvement, I don't have the list of schools that they attend, but they attend wide a range of schools in the across the county. So I would think I would find it hard that schools, or there's children and families that are not aware of oral health.
Make a final point, but it's not working, is it? I mean, the statistics were that 37,000 children, 2018-19, were going to hospital for, this is nationally, for extractions, largely due to tooth decay.
Yeah, no, absolutely, and we know that poor oral health, like any health condition, heart disease, diabetes, cancers, there's a strong correlation with deprivation. So that's part of the Core 20+5 model, targeting our most deprived communities, targeting prevention elements there. A key part of the strategy. It's already been done by the oral health promotion team that's commissioned by the local authority, but the step up in prevention as part of the strategy needs to be taking place. So yeah, it will never be perfect. It can always be improved, and hopefully the strategy goes a long way to setting the roadmap to improve that.
Okay, thank you. I've got Councillor Woodliff next, please.
Thank you, Chairman. Good morning, Carol, Alan and Sarah. Oh, so they've gone. Well, I think it's a scandalous report, actually, in many respects. It represents a scandal. I have to pick out section 2, which talks about the poor oral health has on general health and well-being, and the fact of 2.2 that 4 out of every 10 children in Boston are experiencing dental decay at the age of 5, and the link between social deprivation and poor oral health is in 2.3. And I could go on, I'm not going to do that. But I've got some questions, which is the key thing, isn't it?
Yeah.
My question is, if you compare the east with the west of Lincolnshire, you're comparing an area which has chloridisation with the one which doesn't. As I understand it, the west side of Lincolnshire water has fluoride added to it, and the
Yeah.
east side doesn't. So you
Correct.
have considerable scientific evidence to suggest that, data anyway, that the benefits of fluoridization in water does improve oral health, mental teeth health. Yeah, I accept the fact that fluoridization can have a negative effect on elder people because it can lead, I understand, to hardening of the arteries. But in principle, the purpose of fluoridization is to improve the health of the welfare of children's teeth. So there's no recommendation in this report, as far as I can see, to Anglia Water to add fluoride to the water people live on the East Coast. Maybe that would have a significant improvement in the standard of oral health for children in Boston, because you've got to do something about it. 4 out of 10,
Yeah,
age 5,
no,
it's a scandal, isn't it? Absolute scandal.
I
That's my
completely
first
agree.
question.
You know, it is an inequality between East and West. Fluoride, water fluoridation is protective, and it will be in the strategy, the final strategy of that recommendation.
Well, I've had words with Anglia Water about this. Not that I've got anywhere with it.
Yeah.
It's just a waste of time talking to them. Sorry, but it is.
Yep.
Now, moving on, I mean, there is a definite link between diet also and oral decay, isn't there?
Yeah.
So, I mean, don't see anything in the report here about the fact that children who eat high sugar fat foods, you know, the connection between that and oral decay? Maybe the connection.
Just to kind of point out though that the report was just to outline the work, the process of the strategy. It's not a needs assessment. It's that's already been done by Lincolnshire County Council, their oral health needs assessment that they refreshed just towards the end of the year. The purpose of this report was to cite elected members on the process of the strategy and the work that's going on round about that. So I completely accept these factors, and I said, you know, they're fairly common knowledge that sugar causes tooth decay and poor diet is associated with that. But I said the purpose of the paper that's presented is to cite elected members on the strategy work.
I understand what it's there for. I'm just raising those issues because someone's got to raise these issues. There's serious issues here about children's health. And I'm well aware of what your proposals are, but obviously I want to see an improvement in the health of the children in my area, in Boston and on the East Coast. It's a very, very serious issue because it leads to serious issues later on in life to do with all sorts of other things, so health and so on, to do with heart and cancer and all the rest of it. So there are serious issues to be dealt with. I'd just like to see something in here that kind of combats this. Where are we going to go forward to change these things? Because I don't see any change here. Okay?
No, as I said, you won't see it there because it's a strategy process document. The implementation plan, the strategy, final strategy does raise those issues, and the implementation plan will have a plan for stepping up prevention. So in areas like Boston, let's put water fluoridation to one side because that is a complex and very political situation. As you know, currently it sits with the local authority to make that decision whether they go for full water fluoridation. There was a move when the previous health secretary was in post to take that as a national decision, and we still, with the white paper, public health white paper, we still don't know where that is at the moment. But in terms of other access to fluoride, we know that improving access to fluoridated toothpaste, to fluoridated varnish, all is a way of protecting vulnerable children's teeth from tooth decay. And there'll be a clear message in the strategy and implementation plan to double up in prevention elements in areas like Boston through supervised brushing and fluoride varnish schemes within schools.
Do you really believe that free fluoride toothpaste to adult care homes will actually make a significant difference to the welfare of children? That's what it says in the report, isn't it?
Sorry, could you please repeat? Sorry.
Yes, doesn't it say somewhere in here, I'm sure I read it, about fluoride toothpaste being supplied to people in adult care homes? Is that not so?
Well, you know,
How does that improve?
Oral health improvement, it goes across the life course. So, you know, this strategy is not just focused on children, but oral health. And we know that when people, older people go into care homes, their oral health can rapidly decline if it's not taken care of. People that can't look after their own oral health through disability, for example, strokes, etc., dementia. So that's an area that really needs to be improved. And providing oral health resources, toothbrushes, fluoridated toothbrushes, toothpaste and fluoride varnishes across the life course to children and to vulnerable adults as well will make a difference.
Surely don't think that the welfare of children...
Councillor Woodliff,
must come
if
first.
I can, please, it's not a back and forth, it's questioning
Okay.
and then we get
Well,
an
I've
answer.
asked the questions, Chairman.
Several other answers
Perhaps
as well.
you'd like to come up with some yourself on this, because it represents your area as well, doesn't it?
It does indeed, but as I think has already been said, this is not the actual strategy. We will bring that back to the committee at another point. This is about how the change is going to take place. But I take on board what you're saying, and I think fluoridisation is something that has been back and forth. I think the adults, or the children's committee, should I say, sorry, have been looking at this as well. So there is some work, and I do know that now, of course, it's in the hands of the Department of Health and Social Care. So it will be interesting to see what the outcome of that is.
Thank you very much indeed for your support, Chairman.
Okay, thank you. In which case, I've now got Councillor Thompson.
Thank you, Chairman. The point I was going to raise in the question was in relation to fluoridation, which Councillor Woodliff has raised. I was just absolutely amazed to find that the most deprived areas of Lincolnshire are not fluoridated, obviously have no provision for dental care. I just wonder if there was fluoridation, it would reduce the incidence of dental ill health and might provide a more attractive environment for people to practice dentistry. Thank you.
Thank you. I think from what I recall reading in previous reports that they're looking at actually removing fluoridisation in other areas because they're changing how the pipes are in the system are. So it could actually be a worsening picture than it is where it is now.
Sorry if I may come back on that. I find it very, very regrettable because fluoridation in terms of improving oral health has been one of the success stories of public health over the recent years. Thank you.
Thank you. Okay, I've got Councillor Allen, please.
Thank you, Chairman. I think we're all, as members of the County Council and representatives, our voters, well aware of the issues in dentistry. So I don't think we really need a report that explains to us what the issues are. We've raised them time and time again at this committee, and they're raised time and time again by our voters and residents. There basically isn't a national health dentistry system that operates in Lincolnshire or even in the UK. I am really, and I frequently get comments from residents who say, I can't get onto an NHS list because there isn't an NHS list to get onto, and there are no doctors accepting NHS patients either. And my own nephew has failed to get onto an NHS dentist very recently, and we've had no alternative but effectively to put into the private system because that's where most people go if they can afford to go. And that's where the inequality is. You can say there's an inequality in different parts of the county, but the inequality really is some people, or a good proportion of the population, have to find the money to go privately, and there's a proportion of the population who can't afford that money to do it. That's where the real inequality is, and the person that's caused that is the NHS. And because of the policies that they've been operating and their inability to actually provide a proper NHS dentistry system. I, at one time, many years ago, did have an NHS dentist when this was 10 or 20 years ago, when it was operating in a far better system. But I had to exit from that because the contracts changed, and I went to the dentist and he said, I don't know what you're here for, you don't need any teeth taking out. And my answer was, well, I don't go to a dentist to have teeth taken out. I go to a dentist to have preventative oral hygiene to make sure that I don't need teeth coming out. But that is, I think, probably what's prevalent at the moment. And that's a further inequality, and the people that can't afford to go for descaling etc., then have to go to a dentist of some form or other to actually have teeth out. And moving on to 2-year checkups for those people lucky enough to have an NHS dentist seems to me to be more associated with ensuring then when they do turn up at the dentist, there's a tooth to be taken out and a payment to be actually made. So I think the whole thing is broken, and the NHS doesn't seem to be doing a great deal to actually address that. And this report that we've got, which is called the Lincolnshire Dental Strategy, is really a Lincolnshire dental workshops taking place to deliver a strategy of some form in the future. There seems to be an inordinate amount of people that are involved with dentistry, with teeth, I should say, not dentistry. Although not an awful lot who actually seem to be dentists actually operating on people. And the workshop seems to be coming forward with a range of sticking plasters, although I'm not totally sure whether that's appropriate in dentistry, but I'm not sure what the equivalent form is in terms of dentistry, in terms of putting sticking plasters on things. I don't know where this committee goes, Chairman, because we're looking for a dental strategy. We haven't got one in this report. There seems to be more information that was put on the screen, which is not particularly helpful when we haven't got the ability to actually look at that. So I think we need something that comes back fairly soon that says what it is that might be coming forward from a strategy point of view, although I have a feeling that we may well be looking for a long, long time for that to actually happen until somebody centrally gets to grips with the issue, and then it'll be another 10 years before we see any real benefits, or alternatively makes the decision that it is privatised properly, and provision is then made for the people that haven't got the ability to actually pay for it themselves to be funded in some sort of way so they can get treatment.
Thank you, Councillor Allen. I mean, we will be looking at bringing this back in July, and with the full dental strategy at that point, I think is laying down the groundwork, let's say, at the moment in time, and I think we will be wanting to closely monitor if there are improvements when it's handed over to the ICB. I don't know if there's anything further that our presenter wish to add to that, or if we move on to the next question.
I'm happy to move on, thank you. Or Carol?
No, I was just going to really around the point around the 2-year checkup. It isn't in terms of the contract reform and the guidance that's come out about recall intervals. It isn't aimed at moving everybody to a 2-year checkup. It is more around personalised recall intervals depending on the person's oral health situation. As you said, if they do need that intervention and prevention advice, they would be recalled on a more frequent interval than 2 years. As I say, we appreciate the access situation. It isn't where we would want it to be. I mean, things have been improving a little bit over the last quarter of the year, but obviously for Lincolnshire that's still not in the place that we want it to be. And hopefully, like say, the actions that will come out of the strategy and the work that's going on around dental contract reform will help us to try and move that, at least do some short-term actions to get some of that access situation resolved. And as well as I think coming back to the child oral health issues, that we continue to work with the Lincolnshire County Council on the oral health programme, again, to make sure those toothbrushing schemes and the packs, etc. are delivered. And we support that with the local authority in terms of resource funding, etc., as well as part of our plans.
Thank you. Councillor Parkin.
Thank you.
Most of my issues have been addressed, so I won't dwell too long. And I, as you know, I avoid making a political statement, but I would just like to throw it open to the room that this is not just a Lincolnshire problem. This is a nationwide problem. And we have got to be really, really honest about why those problems exist, and be sure that if we're going to challenge our local people who are brave enough to come and take the flag, that we're also going to take and be honest about what the issues here and how they've arisen on a national level as well, because the two are it's the same thing. It's the same problem, and we can't pretend that this is a Lincolnshire problem and just owned by these guys up there. It's a national one because of the direction of travel nationally.
Thank you, Councillor Parkin. I wouldn't disagree, but I would say it is NHS England that present to us at the moment. And I think a local slant may well help us moving forwards. I've now got Councillor Smith, please.
Thank you, Chairman. Just to confirm on your previous point, you are correct. When Anglian Water do change the pipe, the West will have no fluoridation in their water either. So it's going to get worse. It's not going to get any better, ladies and gentlemen. I welcome the fact the ICB has moved with respect to give dentistry parity with other forms of primary care. For too long that simply hasn't been the case, and it's not just a Lincolnshire issue, as has been said, it was a national issue. It wasn't given parity with other forms of care. Thank you for confirming the strategy will be back, Chairman, in July. That answers my second point. But as Councillor Allen said, even if you have an NHS dentist, it's not free. It's not cheap either. I see mine every 3 months and pay into a scheme so I can actually get an appointment when I need one. So I know how expensive it is. It's £30 a month, which, do the maths, adds up to a lot of money. And I'm very lucky I have an NHS dentist. Should that dentist close, God forbid, I'm out of a dentist. I can't afford to go privately. I have to see my dentist every 3 months. And I'm sure there are many of our residents in the same position. You're quite right, Councillor Parkin, it is a national problem. It's because the government in 2007, from memory, changed the dental contract so that actually it became so unattractive to work in NHS dentistry that they left in their thousands, quite understandably, because it became so complex to actually administer and actually for them to get paid in the first place. And then the government had the cheek to say, oh, by the way, we won't pay you per procedure, we'll pay you in hours. Well, hang on, I've just done 2 procedures. It's time, it's money. I've used 2 sets of tools for 2 sets of procedures. And this direction must, as you said, we have to lobby higher up, and I certainly have, and I can say that categorically, and I'm sure others have as well. But until that contract is changed, you're not going to solve the problem. And unfortunately, Lincolnshire was on a low base to start with, so we're going to feel it more than most areas, because as has already been alluded to by our presenters, we don't have a dental school, for example. We are also very rural and very sparsely populated. So we've been at a low base to start with. We've then been hit twice. It is a national problem. It requires a national solution. And I know it's not the presenters' fault. Here they are merely doing the best they can in the system that they're in. But unfortunately, they're the ones here, so they get the flack, fairly or otherwise. But we really need a new contract as a matter of urgency to put dentistry on a stable footing, because the current contract doesn't even provide on the premise that everybody will have a dentist. Its provision was something about 25% from memory weren't going to access a dentist either through choice or going private, which is total lunacy. Let's be honest, that's where we are, and that's what's causing the problems, and until that's changed, we're not going to solve them.
Thank you. Would any of our speakers like to answer that, or shall we move on to the next?
Sorry, I was on mute there. Just move on to the next, but I don't disagree. There's a lot of valid points there.
Thank you. I thought that's what you'd say. Councillor Linda Wootton.
Thank you, Chairman. My questions have actually been covered by colleagues. I'd just like to say, in my own case, I'm fortunate at the moment I do have an NHS dentist. He's brilliant. He came from Poland about 7 or 8 years ago, but I was speaking to him the other day, and he said that when his contract ends, that's it. He won't be able to cover NHS patients anymore. We don't have a lack of dentists in Grantham, but I know for a fact I will not find another dentist in.
Thank you. I've now got Councillor Cleaver.
Thank you, Mr. Chairman. One of the things I'm not really clear about on this issue is exactly what the opportunities are from this commissioning being devolved down to, as a popular word, being devolved down to our local ICB and presumably to some extent to our local public health functions at the County Council. And I'd like to see next time we get a report on this, for there to be a clearer statement of exactly what the opportunities are that this devolution allows us. Does the ICB actually have additional powers, to concentrate resources more easily and quickly where they're needed? Can it do things that NHS England was unable to do to alleviate the situation? I know obviously if there's a national contract that it has to abide to, there's little it can do, but does it have to abide by that contract? That I'm not clear on. Does it have the power to suddenly say, right, we're going to put a bit more money into this and sort out the problem that we've got in Boston by making that, you know, a special area? Is that an option that's available to us? Is that a strategy? Is that something that we're going to get as a benefit from this government policy?
I'll let Sandra come in there. Sorry, Sandra, to put you in the spot. I can answer as well, but in terms of from the Integrated Care Board.
So hi all. Yeah, I'll come in on that point, but it's probably something we'll pick up in the next paper actually for the presentation. But certainly take the question on board. What we do see is there's an opportunity to integrate more in the local with all of our local services. The comment about there will still be national contracts, but how we deliver and the flexibility within that national contract can be determined at a local ICB level. If at a local ICB level through all of our planning work, there is further opportunities for other services, then we will be able to have that as an option alongside all of the services we commission at a local level. So that will be the opportunity for all of our services, pharmacy, optometry, dentistry included. But I can't say just at the moment is what that looks like sitting here today, but that's part of the reason why Alan is bringing today the paper about the work we're doing on developing the strategy as first signal really about that's our great opportunity of the ICB working with the NHSE team ahead of delegation transferring to us from 1st of April about actually what does the local dental strategy need to look like for Lincolnshire and meets Lincolnshire's needs rather than actually currently being a regional dental strategy which covers 11 ICSs and we're quite different in Lincolnshire compared to the other 10 ICSs within the Midlands. So that's what we've taken the opportunity, and it's very much as, Alan, when you see it in July, be able to see what is our proposed delivery plan that looks like over the next 3 years, what's the actions we're taking, and if any of that then does require further discussion about greater investment or where that is needed, that will be considered as part of the overall ICB planning. I hope that helps, Chair.
Thank you.
Yes, it does, thank you. I think that was very useful. I've got just 3 questions myself, if I may, because I've got no other speakers. So, do you think the changes in the NHS dental contract, which I understand will increase payments to dentists, will make NHS dentistry more attractive, particularly in areas such as Mablethorpe or Skegness?
Carol?
All right, yeah, so this is in terms of the contract reform that's been taking place. So there's been a number of things that they've already put into place from the engagement that they did a rental contract. One of those things was looking at what they called a minimum unit of dental activity value, which they did. That was done on a national basis, and there was a value developed for that. Actually, for Lincolnshire, that didn't really have an impact as it did in other areas, because historically we had previously, as a primary care trust, undertaken our own initiative to look at units of dental activity rates of payment, and we'd come up with our own minimum value at that time. I mean, it goes back some years, but we'd already done that. So at the point of this national implementation, the rates in Lincolnshire, the lower rates of reimbursement, were already above that level that has come out of the national conversation. That's not to say that they're not still revisiting those rates and reimbursement levels going forwards. So that could be something that could have an impact for Lincolnshire. I mean, the other thing with the contract reform is they are still doing further work nationally, and focus groups are being undertaken, I think, or have been overtaken the last few months. And again, they're looking at other areas of the contract that could be developed around how people can access urgent care, how the prevention elements of it are a focus. So there's various aspects that are still in development on the national contract reform. So I don't think we're I don't think we're going to see a completely new contract as such that will come out of the national work around the contract that the dentists currently work under. But there's sort of elements that have been changed in the last couple of months, and further elements that will come through the next year or so as well. But I think Sandra's right to say it in terms of for the Integrated Care Board, it will be whether there's anything else that they can do in addition, I suppose, to the national contract that will, help the situation, whether that's access prevention and other things, and linking in with wider primary care that we can use to improve the situation for Lincolnshire, rather than just looking at what the benefits may come from any changes to the national contract.
Okay, thank you. How do you track and monitor the plans for improvement, and how often will partners meet to assess or adapt plans?
Looking at Alan, I'm not sure yet whether we've till we get the plan, and presumably we will look to have some subgroups for the various themes, because there is a number of themes and actions on it. There will be reporting that will go back through the Integrated Care Board and probably back through to the Midlands region as well, because there will be the joint commissioning groups that we've got. I don't know of the frequency of those updates at the moment, whether that would be something monthly that we would be looking at in terms of the plan reviewing. We do get obviously dental activity data, and in terms of patient data, etc. We do get monthly values for that, and we can see the trends as we go through. So we will be able to see the impact of anything that we do in terms of any commissioning and changes or schemes that are put into place. But I don't want to jump the gun for Alan saying that I'm committing to that we will be looking at it on a monthly basis if that's not been discussed yet.
Yeah, exactly. I mean, just to add to that, I think you covered it well, Carol. Still to fully decided as part of the implementation plan. You'll remember the cross-cutting theme of smart use of data and being needs and intelligence led. To go alongside that with the existing routinely gathered data in terms of oral health improvement through the child survey, and each year that the National Dental Public Health Team do their epidemiological surveys every 2 years. It's 5-year-old children every in between year. In addition to that, we're developing locally a dental dashboard that will take new metrics from that will be looked at in a Power BI sort of dashboard and looked at more routinely. That's still in development, and some national work is going on around metrics to inform that. But in terms of frequency, I'd imagine in linking in that 4 pillars of primary care and integrating dental much more centrally within that. Then the review of the dental strategy and the implementation plan will have 2 key forums in the ICB primary care, and also through separate dedicated dental commissioning meetings as well. So I think it will get a lot of attention, and we know that. I mean, that's the positive direction we want to go, and that's got buy-in across the whole ICB from the top level all the way through.
Okay, thank you. And my final question is, has there been any further progression in regards to a Lincolnshire-based dental school? And in reality, how long might it take to establish one?
So I'm not aware of any developments on that. I know it would be a regional aspect. East Midlands region is the only region in the UK that doesn't have a dental school at the moment. There has been talk about with the University of Lincolnshire opening up their medical programme to see how the feasibility of having dental into that. I know there's advantages and disadvantages of that in terms of staffing it and actually running a dental school. Professor Mark Gussie, who is the Professor of Rural Health in Lincolnshire, who's working with us, is a dentist by background, is an academic dentist. He was the dean of a dental school in the state of Victoria in Australia. And he said, you know, it's so complicated it's easier said than done in terms of setting up a dental school, in terms of what's needed, in terms of staff to actually provide teaching. So I don't think we're any further forward. Where we are further forward is the centre of dental development that's coming through, and that's going to be like a postgraduate, or not solely postgraduate, but for all members of the dental team to develop and develop communities of practice, networks, academic and research, and social networks, just all kinds of networks and communities of improvement as part of that, developing and looking after the dental workforce, developing the culture of pride and worth throughout that. So I think that's a really exciting development, and there'll be more news on that as we go forward in terms of what that centre of dental development will look like. And actually, I think in the short term, that's probably the more likely way to go. And while the discussions about the merits of having an East Midlands Dental School and where that might be located.
Okay, thank you very much. In which case, I'm going to move to a proposal. I propose that we note that with effect from the 1st of April 2023, the commissioning of all Lincolnshire's NHS dental services will be delegated by NHS England Midlands to NHS Lincolnshire Integrated Care Board. To note the information presented on the dental challenges in Lincolnshire and the development of the Lincolnshire's dental strategy. And finally, to agree to receive a report in July 2023 to include the full dental strategy. Do I have a seconder to my proposal? Thank you, Councillor Allen. All those in favour, please show. Thank you. That's supported unanimously. And thank you. We'll move straight into agenda item 8 because we've got the same people delivering it. And so I won't go back through welcoming you. I'll just move straight over to the presentation. We're just seeing if we can load the PowerPoint. Yeah, we're up.
Oh, brilliant. Thank you. We can't see it quite fully on the screen, but can everybody in the room see it okay?
We can, yes.
Okay. Oh, thank you very much. So I'll lead this part of the discussion if that's okay, but I will look to Carol and Alan if there's anything they want to add as we go through. So just by way of start, just for starters, thank you very much for inviting us today to come and provide the update. So I'm Sandra Williamson, Director for Health Inequalities Prevention and Regional Collaboration for the Integrated Care Board. And we've just talked about some of the regional collaboration work on dental strategy as part of the earlier presentation. So if I move over to the next slide, that would probably, so the purpose that you're receiving this today is really specifically to receive an update around the pharmacy, optometry and dental services and the delegation of those areas and how we intend to work both within Lincolnshire and how we're operating across the Midlands and working with the ICBs. So that's the part of the reason for the update today. Can I move on to the next slide? So by way of background for colleagues who may or may not be aware, so part of the delegation of the services from services currently commissioned from NHS England to our ICBs is part of the national policy that was set out in the Health and Care Act in 2022. And really what I set it out is if we look just specifically in this lens around the pharmacy, optometry and dentistry, and we often term that for people in the call and in the meeting pod delegation, is looking at the responsibility for all planning, performance, finance, quality and improvement of those pharmacy services, the dental services, optometry services will move from the NHSE to the ICB from the 1st of April. But that's through a delegation agreement. Therefore, the accountability still of those three services will still remain with NHS England.
and therefore they will still have a function in terms of oversight, anything around the national, which often around national contracts and service specification, that will still be driven through NHSE. But what it does give us, by delegating, and we're on this journey really in terms of, and we've started well ahead of April working with our colleagues in the NHSE team, is try to break down. The purpose of all of this is breaking down the barriers by having this being part of local commissioning within our integrated care boards, and support the join up of the fragmented pathways, which may have happened because of individual commissioning that will have happened at both pharmacy, optometry and dentistry. So what we're really looking at, improving both health and care and outcomes, but we do it in a much more joined up way. So that's really going to be the strong emphasis about the ICB role in all of this. If I move over to the next slide just really talks about, and you will have seen this in the paper, I'm just trying to pull out the key point. So we just touched on, we're going to take on, first box around, we're taking on delegation of those services from NHSE, will take place from April 23. At current present, during this year, it's been very much joint working. So all of the year, really, last 12, 18 months, we've been joint working with both the NHSE team and all the ICBs within the Midlands, forming close relationships with the East Midland ICBs. Applications had to be received for all ICBs in September to be able to progress to delegation for 1st of April. So it's pleased to say that all 11 ICBs within the regional footprint all submitted something called pre-delegation assessment framework and have been approved through that national moderation. It's just now going through the last bit of process to make the formal delegation ready for 1st of April. We've developed, as part of our way of working about this primary care delegation, as I say, we've been working over the last 12, 18 months, is developing what the operating model will look like for this function to be able to be delivered across ICBs, but it also importantly about what that would look like at local interface level. Currently, the operating model, the way we're seeing it work, is it will work across 2 teams. There'll be one team working across East Midlands and one team working across West Midlands. And for the purposes of, again, colleagues may not be aware, when we're talking about East Midlands, we are talking Lincolnshire alongside Leicestershire, Northamptonshire, Nottinghamshire, Derbyshire in the main. So there's five ICBs within the East Midlands footprint. What we are looking in terms of the workforce that currently supports, so Carol and her team as an example, that currently employed within NHS England to support this function. They will still be supporting the function, continue to work very closely with us, and that delivery model to support that function and all of the important staff and teams within that function will be hosted with one of the ICBs within East Midlands. Our current working agreement, as included in the paper, is we're looking to see if Nottingham would be a host for that function. And that's mostly to keep the function and the specialism and all the resources together across that East Midlands footprint, but very much working to the 5 ICBs. We'll have appropriate governance in place to support that arrangement, working across the 5 ICBs. Carol's just talked about some of our joint committee discussions, maybe where we see the benefit of operating on a, when we talk about 5 ICBs across East Midlands, we're talking about like a 5 million footprint. And when we're looking at us at Lincolnshire level, then we'll be looking within our own ICB governance, which is a local ICB footprint, so anything under 1 million maybe. And then they'll be looking at any of the committees to deliver the function, as well as any of the working arrangements between the teams. And all of this is on the premise that we want safe transfer and all of the work to make sure that we're ready for 1st of April. And there has been joint working groups in place for quite a while now, certainly over the last 12 months, just to make sure we're managing risk, we're supporting the transition, and hopefully that'll be a smooth transfer for ICBs ready for the 1st of April. That's all. There's a bit more detail obviously within the pack, but what it will mean, if we move on to the next slide, is that all of our core principles and our approach to delegation has been very much about partnership, co-producing together across the 11 systems, working closely through the East and West Midlands, so myself, working with other directors within the East, and also the chief execs have also been working across the East footprint along with our chairs of each of the ICBs. That will ensure that we have safe transition. We're sharing the knowledge and skills and expertise, and we're trying to ensure that there's as much minimum disruption as possible through all of that. But obviously, it's been quite a big process to do over the last 12 months. The last slide, if that's okay, is mostly just to talk about so what it will mean. We've talked briefly about it will be the coming together of the teams that work across the East and West Midlands footprint. We are very much looking at how the collaboration between ICBs is expected to work across the East, and that's mostly for some of the contractual and transactional functions. We're very much around if there's only service improvement or transformation that's applicable to one area, that will be very much delivered in that local ICB footprint. All the contractual relationships and the standard frameworks managed through that hub approach across the East Midlands, but again making it really clear that we're expecting that whilst there are national contracts in place, we are expecting some flexibility, and how we deliver that will be down to within the Lincolnshire ICB, as touched on earlier with the dental example. At this stage, there is still something called reserved functions. So whilst I would say probably majority, and Carol might be able to confirm it for us, majority of the functions are being delegated to the ICB. There is a small level of reserved function that will stay with NHSE. And as I outlined earlier, they also have an oversight accountability function that they'll retain. So it's quite a small element we're expecting for POD, and that's just to be confirmed. Still working on that, ready for 1st of April. In terms of the future operating model, the most important part now in the last 2 points around the interdependencies. So we're just making sure when the way we're working in Lincolnshire is we've made sure from an independency, you may come across it, the development of the 4 pillars of primary care. So when we start talking about primary care, we are talking about general practice alongside pharmacy, optometry and dental services. So that's been our approach for the last 12 months. That's seen under that umbrella of the 4 pillars of primary care, is that they're very much now integrated with all of our clinical and care directorate and some of our governance arrangements within the ICB. It's also ensuring that we have, as part of our clinical advisory support, represents POD alongside primary care. So that's part of supporting that integrated discussion at our clinical leadership level. That will support then on transformation and service improvement. I think Alan was just alluding to earlier some examples that already came up through the dental strategy development. It's the first area we've started to work as an ICB earlier than April on strategy development for Lincolnshire of the POD. We've immediately seen the benefits of the transformation CANRE around frailty and the frailty power of pathway and the oral health, which will link to some of the work that the ICB will already be doing with all of our partners about improving services on the frailty pathway. So hopefully that's the end of the slides. I'm happy for you to take them down. That's bit of a run through really in the preparation for delegation ready for 1st of April. Hope that's helpful. I'm happy to come back at any other future time once we've been delegated that function, of course, as an ICB.
Thank you. Councillor Allen.
Thank you, Chairman. A business model that has accountability for deliveries of services with one organisation and responsibility for delivery of those services with another organisation is an interesting business model. I'm not totally sure I know of one anywhere that actually works with that sort of basis. So I wait with interest to see what happens with integrated care boards. The more important thing, I think, in terms of integrated care, if we're talking about integrated care, which is presumably what's behind an integrated care board or an integrated care service, is where social services actually exist. And I've heard nothing at all in the report so far about integrating primary and secondary NHS care with social services and looking after the elderly. So is there anything that could be added to the presentation in relation to that? It's particularly relevant, you know, when we know that one of the major problems within the NHS service at the moment is bed blocking, and bed blocking is caused by the inability of the NHS to actually move patients out of hospitals. and the lack of coordination, should we say, between hospital patients and social care homes. Because there are, I mean, in Lincolnshire in particular, there are vacancies within the national, within the social care homes that exist at the moment, but there does seem to be a great difficulty in moving people from one environment to another environment, and that seems to be fundamentally what's behind all the problems at the moment. Well, not all the problems, it's entirely wrong to say that, but the current problems that seem to be exacerbating.
Councillor Allen, I'm just going to hone you in on this is for the pharmaceutical, optometry and dental. It's not, you know, so much about the function of the ICB as a whole. I think it's just to try and hone in on that. I think that's an entirely different conversation, perhaps.
All right, well, I'll raise a different question then in relation to the actual paper. Can somebody inform me? It does seem that even dealing with this particular aspect of integrated care, there are a lot of resources working on delivering the transition and presumably delivering the model in the longer term. Can somebody tell me whether these resources are being moved away from core duties at the moment within the National Health Service, or whether these are new resources?
Thank you. Do you want me to come in and then I'll probably look to other colleagues? So, so part of the current resources are developing this, but it would be what we were working to anyway as part of our integration work. And the NHS team, for example, already had arrangements in place in terms of that local support and that local integration. I think what this has given us is the added opportunity through the delegation process to work even closer together. So we've built on an infrastructure that was already in place and working really well between the NHSE and the Lincolnshire team. Does anybody else want to add anything else, or are we happy to move on to another question?
I was just going to add, Sandra, that's correct. In terms of the NHSE resources, it's the existing team resources, isn't it, that are linked in and working on this, and will be part of, like you say, although we'll stay as an East Midlands wide team, we still will try and have so many individuals who can be more local ICB facing and working with ICB colleagues as well.
Chairman, I'll be a bit more specific. So whilst there might be NHS resources working on this, and maybe not new NHS resources working on it, although that perhaps needs confirming, are there additional resources now involved in this whole process of providing an integrated care service?
Not currently, no. There isn't any additional services at the moment. We're doing it from the existing resource and working in a much smarter, collaborative way, because that does affect working with the East Midlands ICBs that I've also touched on through this discussion.
Okay, thank you. Dr. Thompson.
Thank you, Chairman. The pod services all potentially have a conflict of interest between NHS and commercial services which each of the provider provides. How is the ICB going to be involved in monitoring whether there is a conflict of interest and the commercial services provided by the contracted providers? Thank you.
Thank you. That's a really good question, and we are building on the processes that currently exist. So I'll just ask Carol to come in on that, because then that'll be the committee arrangements that we'll continue then as part of our East Midlands joint commissioning work, and individual ICBs will also have a duty to safeguard on that too.
Yeah, I mean, currently our existing governance arrangements and going forwards, those joint commissioning arrangements, there is a process in place in terms of trying to manage those conflicts of interest. So if there are professionals involved in that, and there could be a potential conflict between, like you say, the NHS and then their independent element of the work, there is documentation, etc., that people have to do, declare if there is that conflict, to how that conflict could be managed or not, or if it's not able to be managed, then obviously their involvement in a particular work programme will then be assessed to make sure that, like you say, it would always be managed in a way to ensure that that conflict isn't there in any decision making processes that we have. And I think going forwards that will still be the case, even if those groups expand and we work across more ICBs and with more colleagues, that conflict of interest process will still be in place.
Okay, thank you. I can't see any other speakers expressed at the moment, so I have 3 questions myself. The first is, how will the ICB approach differ from NHS England, and will the ICB have more freedom around recruitment and retention planning?
So I'll probably come in to start, and then I think it will link to Alan and the strategy we talked about. So I think I've already started to talk about how our ICB approach is different, and I'm giving the example. There's 2 probably live already. The approach we've taken so far on the dental strategy development, very much owned in Lincolnshire and working with the NHSE team to develop that. So that's been an opportunity that's different, and we expect to do that for all of our service areas, whilst dental was the first area we prioritised. And the other area, secondly, is that transition and the interface with everything else we're doing in an ICB. So embedding pharmacy, optometry and dentistry within all of our governance arrangements, in our service development and priorities and planning. And I've just touched on around the work we've been doing on developing our clinical leadership within the ICB includes representation of POD. And we've started that journey now ahead of delegation to make sure that at transition we are ready and fully started to embed that thinking before April. And so that's been different, really, because that's been the opportunity we've been able to do at a local level, which has probably been more difficult to do at a regional level that's spanning 11 ICSs. So they're the 2 examples to start with, but there'll be more, I expect, as we get into more of the business from April as an ICB. I'm joint working with the other ICBs. Alan, is there anything you want to add to that from your observation so far?
I think you've covered it, Sandra, and I think it just closes the loop nicely back on the whole reason that we're doing the strategy and the key themes and the workforce aspect and that development coming through, and it just aligns nicely with it. You know, I think we are on the front foot with that going forward. As I said at the start, it's a challenged environment. We know it is a national issue. There's particular issues to Lincolnshire. I think there are real opportunities for having that local based commissioning, place based commissioning with primary care networks, thinking of that 4 pillars of primary care. You know, there'll be much more local, formal and informal relational accountability at a primary care network place level between GPs, pharmacies, going to dental practices. You know, there'll be much more local accountability in an informal sense, and actually formal structures of having the primary care networks, having that 4 primary pillars of primary care represented there. So that's some of the biggest opportunities, I think, that will change the tone as it is now from that regional base, as you say, covering 11 ICSs in the whole Midlands, to a much more local footprint. So yeah.
Thank you. And then again, cutting across sort of this item as well as the previous, is the ICB considering applying overseas for dental staff? And if so, when are you likely to begin this type of recruitment? And what other new and innovative ways are you looking to start recruiting that hasn't been used previously?
I might go to Carol for starters. We have been in this space before on our workforce planning, so Carol might be able to give a bit of an update. And I know we haven't got Kenny on the call, who's our dental chair. I know that this is very live at the moment about overseas dental recruitment, but it's nothing new in Lincolnshire. So I'll bring Carol in.
Yeah, I mean, obviously at the current time there isn't a scheme in place that we're considering about recruitment from overseas dentists. I think it was something that has previously been, certainly was being considered pre the pandemic, but again, what we've tried to do it more recently, rather than looking at that scheme and the development of it, is we've done within the Midlands what we've called a local, like it's golden allow scheme. So we've tried to support recruitment and retention through that local scheme, really, in terms of offering incentives to practices to be able to recruit staff. So it's like a one-off payment to attract them to the area, and the scheme is designed then to retain them for a number of years as a result of that additional funding. So that's the sort of more the approach that we've taken recently with in terms of recruitment retention schemes. But again, I think looking at the strategy and the workforce and those elements of it going forwards, again, you know, I'm not saying the overseas element is not in that mix. We just need to look at, because I think we have started looking at workforce, again, recruitment retention across the wider primary care, and especially in Lincolnshire, what's been utilised in the past, what might work going forwards, again, for dentistry and primary care workforce initiatives. Because unfortunately for Lincolnshire, it isn't just dental as well. We do have similar issues with pharmacists as well. So there is wider that we need to look at with primary care recruitment and retention, I think, going forwards.
Thank you. And my very final question, then, I've got Councillor Woodliff, who's coming last minute, and he'll ask after me. Do you expect the new commissioning arrangements for dentistry will lead to improved access to NHS patients right across Lincolnshire?
So yes, quick answer, yes, I'd expect to. Expect to see improvements, and I certainly would expect to see improvements of the work we've already started scoping with our dental strategy work, and we've already got some great ideas that we can start to progress now as part of that action planning. So yes, we're very much interested. The focus here is improving access, experience and outcomes for all of our for all these services and for our patients. Alan, is there also something you want to jump in as well?
Yeah, exactly, yes. I mean, it links back to that question you asked before, Chair, about whether we thought that the contract reforms, the tweaks to the contract are going to make a difference. I think it's a combination. It's what's happened, those changes nationally, which of course are just the start. And I think there's much more scope for, depending on the outcomes of that, for further contract tweaks around that. There's, because the local flexible commissioning, there's some control over that. So I think it's just that, with the shift of commission to local and the levers that gives us. I think what the strategy needs to do in the implementation plan, being smart, is to use those levers and use those influences, what's happening, changes with the contract nationally, what we're doing locally, and use that in combination together to make a difference. But yeah, the goal is, of course, absolutely that access will be improved. That's a core pillar of the strategy, and we'll be watching that very closely.
Brilliant, thank you. Councillor Woodliff.
Thank you, Chairman, for allowing me to ask. I agree with everything you've said, by the way. I think you've summed it up perfectly. I remain unconvinced by this. I think just a managerial shuffle. I cannot see how it's really going to improve the quality of care at the coalface, at the front line. I don't think that offering golden hallows to people in other areas of the country is going to improve the service here. We need to recruit more people from abroad, as you pointed out. So what I want to say basically is I fully support what you've said, but I remain highly unconvinced by this. I think it's just a managerial shuffle, and it's not going to make any difference to the front line. Thank you very much, Chairman.
Thank you, Councillor Woodliff. In which case, I'm just going to move straight to a proposal that we note the report and to look forward to the delegation of the commissioning of the pharmacy, ophthalmology, that was a mouthful, and dental services to NHS Lincolnshire's Integrated Care Board, leading to improvements across all three services, we would hope. Do I have a seconder to that proposal? Thank you, that's seconded. All those in favour, please show. That's supported unanimously, thank you. And once again, thank you to our presenters for your time. We'll now move on to agenda item 9, the work programme. Simon.
Thank you.
Thank you, bye.
Thank you, Chairman. Referring the committee to pages 66 and 67, which detail the items coming up for the next few months. There are no changes to the work programme as listed. As the committee will see, we do have an item, as was mentioned earlier on, from United Lincolnshire Hospitals on their recovery and restoration of services. Also next month, there is an item on the non-emergency patient transport service, which hasn't been an item on this committee's agenda for a year or two now, as a full item. And then the Director of Public Health's annual report, which is the first annual report from the Director of Public Health covering the whole of Greater Lincolnshire. So I'll stop there and pick up any comments from members of the committee. Thank you, Chairman.
Any comments from members? Obviously, there's other parts that will have been picked up from today's meeting. So in which case, we're all happy, and I'll draw the meeting to a close and would just like to thank you all very much for your attendance. Thank you.